Give us a countdown, please.
Yes.
Yes, sir. We will go live in next 10 seconds, sir.
Ashok sir, you start.
So, sir, is 3,
Just 1 minute, sir. 1
2,
minute.
1. Sir, over to you. We can live to the attendance.
Yeah. So, good morning, everyone, all dear faculty, all dear students. Today, on second Sunday of our month of October, in the festival season, we are here with you and with another episode of ICOG. And today we are with us. Before we start, we have Dr. Parag Biniwala with us. I think I invite Dr. Parag Biniwala to say a few words and welcome you all.
Thank you, Dr. Ashok. Good morning. I bring greetings from ICOG, and it's indeed a pleasure to address the another episode of PG Clinics. And at the outset, let me appreciate and congratulate the conveners, Dr. Ashok Kumar, who's the current Vice Chair of ICOG, Dr. Ashish Kumar Mukhopadhyay, and Dr. Hafizur Rahman. And hats off to these three gentlemen because they are managing this program for nearly 4 years now. So it needs a lot of hard work and a lot of commitment towards ICOG. Thank you very much for this. I also welcome our faculty today, Dr. Arup Kumar Mazi. Welcome, Arupda. Then later on, we'll have a lecture by Dr. Vasudev Panikar, who will talk about the PPH cannula. And of course, there's going to be an interesting case discussion. The cases will be presented by Dr. Deepika and Dr. Shalini. Thank you, Dr. Amruta, the coordinating faculty, who's an assistant professor from AIMS Nagpur. And the examiners, of course, who are going to ask a lot of questions to the students. So students just take this as an exam, a mock exam, and of course the final exam will be easy because they won't grill you for 1 hour. But today you will be actually grilled by our examiners almost for 1 hour, and it will be a great learning experience for you. I welcome the examiners, Dr. Ashish Kumar Mukhopadhyay, Dr. Kartika Prabhu, Dr. Pranay Fukan from Dibrugarh, Dr. Naina Kumar, and Dr. Anuradha Panda. So I'm sure for all the students who've joined, it is going to be a good learning experience. But don't forget to participate in the quiz because some nice prizes await you. And the quiz is conducted by Dr. Archana Kumari, who is the chairperson of the quiz committee of FOGSI. And today we have Dr. Dipti Gupta with her, who will be assisting her. So happy learning to everyone. Best wishes to the students. And in advance, happy Diwali to all the viewers here. Thank you very much.
So thank you, Dr. Parag Biniwale, our chairperson of ICOG.
Transmission power.
Yeah, I
Yes,
think
sir.
Hafizur take over.
Ashish, thank
Ashok
you, sir.
sir.
I think Ashok sir was disconnected. Ashish, sir, you can say a few
Hello,
words, sir.
hello.
Yeah,
I'm audible.
yes, audible, sir.
Yes,
Ashok, sir.
Hello, I'm audible.
Yes, yes.
Yes, sir. You
Yeah.
please go ahead, sir.
So good morning. Thank you, Dr. Parag Biniwale, for giving us your word of appreciation. At the outset, I would like to thank FOGSI President Dr. Sunita Tendulwarkar for giving us this opportunity and supporting us all the times. I thank Dr. Parag Biniwala, Chairperson of ICOG, and Dr. Sarita Bhalerao, Secretary ICOG, for supporting, and under their guidance and initiative, we are continuing with this program of PG Clinic. We are thankful to Dr. Suvarna Khadilkar and all other ICOG GC members and all the FOGSI office bearer for their continuous support to run this program. I'm also thankful to my co-coordinators, Dr. Ashish Mukhopadhyay and Dr. Hafizur Rahman. They are with me for a long time and they are helping us and they are the torchbearer to run this program. And I am also thankful to these our faculty who are time to time supporting.
Ashok, sir, you are muted, sir. Sir, you are muted. You are
Yeah,
Yes,
I'm
sir.
audible. Yes, yeah. So again, on this second Sunday of this month, we are with the program as per our NMC guideline, where we are having competency-based program, and we have to develop the skill of the students. So we start with our program on fetal skull and maternal pelvis, where our faculty, Dr. Arup Kumar Maji from West Bengal, uh, Santi Niketan Medical College. He will be discussing and demonstrating fetal skull and maternal pelvis. And then we have our students from All India Institute of Medical Sciences, Nagpur, Dr. Deepika Yadav and Dr. Shalini Dange. They will be discussing the case on primary amenorrhea. And you know, this is a very important case and it comes in the exam. And Dr. Amrita Chaudhary from AIMS Nagpur will be the coordinating faculty. And I welcome all our faculty, Dr. Ashish, Dr. Prabhu, Dr. Fukan, Dr. Naina, and Dr. Panda from different parts of the country. They are here, and I thank you, madam, for sparing your valuable time. And I hope your guidance to the student will help in understanding the topic. And in the end, we will have topic on PPH suction cannula. And you know, Dr. Panikar, he is the man behind it. And he will be here to directly answer your questions or queries if you have for better understanding the use of this cannula with in the situation where you are dealing with PPH. And in the end, we will have quiz on amenorrhea. And as usual, our committee chairperson, Dr. Archana Kumari, will be there to have this program with all of you. So thank you so much for joining us today. And I now hand over to Dr. Ashish Muddapagyay first, and then to Hafizur Rahman to run the program. Thank you very much. And before that, I also remind you that recording of all these programs are available on our website of ICOG. For your later, you can visit this website and see these programs and get all the benefits and revise your topics. Thank you very much.
Thank you, Dr. Ashok Kumar. And yes, we are crossing 4 years now.
Chalo.
Completing 4 years now. This program started very modestly, humbly in 2022. And you know, the journey is a long journey. We started with very simplistic things, and gradually, as the time evolved, along with the NMC guidelines evolved, we have modified ourselves. We have repeatedly said this. The latest addition was a quiz program to make it more interesting. And since then, the popularity graph of this program has increased. However, knowledge is the basic of our program. And this time, we are going to introduce a system apart from the dummy fetus and pelvis and case presentation. We would like to see the students examining or rather witnessing a suction cannula, which was devised by Dr. Panikar. He will be here. And for the benefit of the students, we might introduce the other type of suction cannula later on also. So that will depend on how the things go and how much the students show the interest. So with that, I think we are gradually evolving regularly, and we will do that. We'll continue to do that for the interest of the students who are appearing at the examination. And my request to the students that kindly take this as a mock examination, treat it as an examination, because you cannot have wrong things done at the examination. Before that, you can have the wrong things done here. So that is the purpose of this mock test. Thank you very much. And I would like Hafizu to start the program immediately.
Yeah. Thank you, sir. Good morning, everyone. As I would like to thank you again, the FOGSI president and our ICOG chairperson, Dr. Parag Biniwale, sir, because it has been the constant encouragement of the ICOG chairperson as well as vice chairperson, Dr. Ashok Kumar, sir, who has been the constant pillar of strength for encouraging these programs to continue. We have completed 4 years and running in the 5th year. And this program has been again designed actually by some suggestion of the students, because in the recently program, Sir Ashish sir, we have seen the students are actually having many problem, even having some basic thing in the fetus and pelvis. Based on their suggestions, we have included some topics, and we would like to encourage the students to give their suggestion what they actually want to have in the future programs. Because as Ashish sir said, program has been strengthened by actually the wish of the students. Many times students say what they actually want. So student then can come there with suggestion. And we have so many faculties for having us to teach the students. So for the first session, this is one session where Professor Dr. Arup Kumar Maji sir is there. He has been often as demonstrating. He has been a great teacher. So today he will demonstrate on various landmarks and diameters of fetal-pelvic relationships, their clinical and obstetric significance, which sometimes becomes very time difficult for the students even to start up. So in their examinations, and I'm sure this is going to be very much helpful to the students. So without wasting too much time, I would like to request Arup Kumar Maji sir to start with the program with the first session. Then followed by we'll have the case sessions. So over to you, Maji sir, for this session, for the first session, for demonstrating those all the basics and as well as nitty-gritties for postgraduate students. Over to you, Maji sir.
Thank you, Dr. Hafizur, Professor Hafizur, for your nice introduction. And really hats off to all of you, particularly the Ashok Kumar, Dr. Ashish, and you, continuing the program for the 4 years. And thank you, our president, and also the chairperson of the ICOG, Dr. Parag. So actually, Dr. Hajipur requested me for some of the basics of the fetus pelvis, and this is very, very actually essential for all the students. Though basically it is for the undergraduate students, but postgraduate sometimes they miss these types of the basic things of the fetus pelvis, and for stressing on the other subjects. So that is we will do it. I think it will be very helpful for you. I also the details of the basics of the fetus pelvis. Now you see first we will start with the skull, that is the fetal skull, and then will the fetus then the skull with the dummy fetus, and then the pelvis, and then the relations of them, and the few important points things more for the postgraduates. Now, if you see the fetal skull, I think it is visible, well visible. I think it is well visible. Yeah, well visible.
Yes, sir.
So
Please,
the fetal
please
skull.
go ahead, sir. Yeah.
Fetal skull is actually consists of that is the parietal bones and the parietal bone and occipital bones and the frontal bones, and these form the vault of the skull. And they are united by the sutures and the fontanelles. If you see the sutures, sutures actually the unossified line demarcated by the flat bones, bounded by the flat bones. The two flat bones are this one is the parietal, bone, and other parietal bones, and the occipital bone and the frontal bone. And there are different types of suture, as we know. This is the lambdoid suture, two lambdoid sutures, and it is the posterior fontanelle or the lambda, that is posterior fontanelle of the lambda, and one is the parietal suture, and two coronal sutures on two sides, and another is the frontal sutures. And this frontal suture, all the sutures is usually ossified, and except that the frontal suture and the anterior frontally, they are the anterior frontally ossified in 1.5 years of the age of the. So these sutures actually some advantages also. These sutures has advantages also, and the fontanelle has the advantage. Posterior fontanelle, that is the lambdoid, that is the it is the triangular Y-shaped 1.2 centimeter diameter, it's almost hard. But the anterior fontanelle is the anterior fontanelle. It is actually the membranous diamond shaped 3 centimeter and 3 centimeter each there. it is situated between the frontal bones and the parietal bone. And lambda that the posterior frontal is situated between the occipital bone and the parietal bone. The advantages of the sutures are there during the delivery, there are only sometimes some molding occurs. That is the molding occur, that is the overlapping of the physiological. If there is a excessive molding, what will happen? There will be there may be the stress on the brain, maybe will be associated. So physiological molding, we know physiological molding are classified 0, 1, 2, 3, the 4 graded in the photograph it is included. That is the overlapping of the bones. And the second thing is that the importance of the sutures and the fontanelles are during PV examination. We will do the PV examination. You will can palpate the sutures, and the sutures and the fontanelles, and you can determine the position, the position, and also the attitude. If it lies in the like this, in the left occipital posterior position, you can palpate on the left side, so that the posterior frontal is palpated, that the left occipital anterior like this, and the anterior frontally is like this, like the posterior frontally is palpated, like this. And if in case of flexed attitude, the posterior frontally is palpable, but in case of deflex or more extension, deflex attitude, the anterior frontally is palpable. Normally, in normal lever, the posterior frontally should be that is the lambda should be palpable. So these are the importance. Other importance is that in case of hydrocephalus, you can diagnose by palpation. So there are some more other importance. I am not going into detail. So this is about the suture and the fontanelles. Now the different areas. The one is the vertex area. This is a very common thing, very basic thing. But still, I said the students do mistake. Where they do not practice it. It is some definition is there. That is the area of the vertex, and other is the face, and there is the brow. You must, all the students must well known, and you will describe it. The area of vertex. It is the area of vertex is the quadrilateral area, anteriorly bounded by the anterior frontally, posterior by the posterior frontally, and laterally two arbitrary lines over the parietes. So this is the quadrilateral area. Just show it like this. So this is the area of vertex. And the area of brow, it is the area, one side it is bounded by the root of the nose and the orbital ridges, and another side is the anterior frontally, and the anterior frontally the coronal suture. So this is the area of the brow. And area of the face, there is from the root of the nose and the junction of the floor of the mouth and the neck. These common mistakes by the student, they show on the frontal bone, not actually the mentum, not the mentum. If you take this, you show the area of the face from the root of the nose, the supraorbital ridges, and the junction. This is the junction of the junction. There is the junction of the floor of the mouth and the neck. You see clearly the junction, not the mentum. So area of the face is like this. So this is now the area. These areas is actually comes in the different attitudes. These areas is what are the different attitudes I am coming to. After that, I am going to describe you what is the girdle of contract. Girdle of contract means this is a very simple thing. That the circumference of the fetal head, which comes in relation with the pelvic brim. That is the girdle of contract. And depending upon the attitude of the fetal head and position of the fetal head, different girdle of contract, circumference changes or girdle of contract may comes in relation with the pelvic brim, the girdle of contract. Now come to the different diameters. There may be the anteroposterior diameter. There may be in different model of contact, different anteroposterior diameter and the transverse diameter. Suppose the anteroposterior diameter, if the put the like this, you would like this, the anteroposterior diameter, if the completely flexed vertex, there may be incompletely flexed vertex, there may be the deflex vertex, and there may be that is the face, that is the brow presentation, partial extension, incomplete extension, and full extension. And in case of completely flexed vertex and incompletely flexed vertex, and also the that is the deflex vertex, all the presentation is vertex, as I have already said, the vertex. But in case of partial extension, there will be brow presentation, and extension maybe. In case of face presentation, there may be two types of extension. One is the incomplete extension, and one is the complete extension. Now you see like this. Here you can see with the dummy fetus, you can see there is the completely flexed. That is the complete completely flexed. This is the completely flexed. Then is the incomplete flexion and then deflection. These are three vertex presentation, and another is the next is the brow presentation, while the partial extension brow presentation. You can see this is the brow presentation. You can see the brow presentation, and more extensions occur. The face presentation occur. More extension is divided into two. One is the incomplete extension and complete extension face. So then what are the different diameter of this type of different presentation and attitude? Now take the this. If the completely flexed vertex, the diameter is suboccipitobregmatic. It extends from the occiput, occiput up to the middle of the middle of the anterior fontanelle. So this is the suboccipitobregmatic, which is 9.5 centimeter. Presentation is vertex. Then comes to the incompletely flexed. Then the occiput, same subocciput region, that is the same point, but anterior point is slightly anterior, and the students often mistake, and also they are confused. What is the anterior point of the suboccipitofrontal? This is actually the anterior end of the diamond-shaped anterior fontanelle, or middle of the forehead. Same thing. This is the middle of the forehead or anterior end of the anterior fontanelle, middle of the forehead. So this is the anterior point. These points are sometimes confused by the student. Suboccipitofrontal diameter, which is 10 centimeter. And then is the occipitofrontal. Occipitofrontal is the from the occiput, from the that point sort of from the subocciput. And this is the occipitofrontal from the occiput to the root of the nose. It is 11.5 centimeter. It is the 11.5 centimeter. Behind like this, behind is the occiput, behind occiput, and this is the anteriorly is the root of the nose. You can see anteriorly is the root of the nose. It is 11.5 centimeter. It is the deflex vertex. Commonly the head engages in this diameter in case of occipito-posterior position. That is one cause of the delayed engagement of the fetal head, the larger diameter deflex head. Now come to the partial extension. Partial extension is the mento-vertical, from the mento, the highest point of the sagittal suture. This is 14 centimeter, and at that time the presentation is the brow presentation. So in case of term pregnancy, patient is in labor, the persistent brow presentation, the diameter is 14 centimeter. So in case of 14 centimeter, there is no such diameter in the pelvis. If you continue to there will be obstructed labor, and so the cesarean section is the answer. There are some small maneuver, but it is very difficult to do some maneuver to change to the face into the vertexes like that. But this is the common rule is to do the cesarean section if the bow presentation, persistent bow presentation in patient in labor. And diameter is mento-vertical 14 centimeter. Now in face presentation, the incompletely extended face from the incompletely extended face is from the root of the that is the incompletely extended face. The diameter is submento vertical. It is the 11.5 centimeter. The submentum in the root, that is the junction. That is the junction from the junction and to the highest point of the caesarean, highest point of the sagittal suture. That is the 11.5 centimeter. And suboccipital and submento bregmatic is actually from the submentum up to the middle point of the bregma. That is around 9.5 centimeter. So the same diameter going completely extension, the same diameter in case of vertex presentation, completely flexed and vertex presentation and completely extended presentation. So one important question is why the face is the abnormal presentation if in spite of that the diameter of Saint anteroposterior. Because the answer I am coming to that, there are so many answers, but important answer is that in case of vertex presentation, the circumference is the sub-occipitobregmatic, and at that the bipalatal diameter lies the largest bipalatal diameter transverse diameter. But in case of face presentation, the circumference is the circumference in case of face presentation is the submento bregmatic submenso. It is the actually malar, submenso malar or temporal diameter, and the bipalatal diameter, that is the largest diameter, lies far behind, and only the transverse diameter is the bipalatal diameter at this level. So maximum bipalatal diameter lies above. That is on the delayed treatment. And also one thing is that this is not a good dilator. Face is not a good dilator. There is a chance of early rupture of membrane. There is a chance of cord collapse. So that is also important. Not a good cervical dilator like this vertex. That is one of the common question is why the face is abnormal after labor. And now after that, after the anteroposterior diameter, you come to the transverse diameter. Transverse diameter is the bipalatal diameter, one, and the supra-subpalatal diameter, and another is the bitemporal diameter, another is the bimestral, not so important. Bitemporal diameter is the 9.5 centimeter, bitemporal diameter. And supra-subpalatal diameter, this is the above the biparatis, another is the below the surface. It is 8.5 centimeter. This is important for engagement in case of flat pelvis, supra-subpalatal diameter. And this occurs also in the normal delivery, normal mechanism of the labor, where the sagittal suture, if you know the term, the asynclitism. The asynclitism is a term. Asynclitism means when the sagittal suture lies transversely directly. That is called as a synclitism. And asynclitism, the sagittal suture deflects posteriorly or anteriorly. That is asynclitism. And in case of asynclitism, what happened? The lesser diameter, that is the supra-subpalatal diameter, passes through. If the pelvis is small, particularly flat pelvis is occur, even in the normal menagerie, the asynclitism, majority of the cases, asynclitism for easy delivery. So this is on bipalatal, supra-subpalatal, and another is the bitemporal. Bitemporal is the 8 centimeter diameter. Bitemporal is the 8 centimeter diameter is the transverse diameter in case of face presentation. Transverse diameter in case of face presentation. So these are the about the different diameters. Now some important points. Now what are the different the dummy pelvis. What do you mean by lie? That's the basic thing. What has Dr. Hafizur has said. What do you mean by lie? Lie is the relation. Lie is the relation between the fetal axis with the maternal spines or the centralized uterus. This is the lie. Lie may be longitudinal lie, lie may be transverse lie, and in between that, then the lie may be the that is the oblique lie. That may be the so lie, and next to the lie, what is the presentation? Presentation is that part of the fetus which comes in relation to the lower uterine segment. There is a lower uterine segment, that is the presentation. And there is another term also, what is presenting part. In fact, the presentation and the presenting part are often used synonymously, but if you go in more depth, the presentation is the broad term, that is the cephalic presentation. That is the cephalic presentation, that's the head presentation or cephalic presentation. And presenting part is the precise part of the presentation which comes in relation with the internal os. Internal os only can be known by the PV examination, internal os. Like the different presenting part is the vertex, another is the brow, and another is the face in case of cephalic presentation. But we often in practice uses the term, the synonymously, because vertex is always use the vertex presentation. But for academic purpose, you know, the presentation and presenting part are two different. So this is about the lie. So, and you also know the presentation is that part of the fetus which comes in relation with the lower uterine segment, that is the cephalic presentation, that is the podalic presentation. And presentation may be also the shoulder presentation in case of transverse lie. There is the shoulder presentation. So, podalic presentation, cephalic presentation, and the shoulder presentation, cephalic is divided by the with the 3. So these are the about the lie. Now, what is the total? A lie is longitudinal in majority of the cases. In 99.5% cases, lie is longitudinal, and vertex cephalic presentation is the 96%, and buttock, that is the breech presentation, is the 3%, and rest 5% is the shoulder presentation. That is the shoulder presentation is less shoulder presentation. Now, what is the position? Now the important part is what is the position. And before that, I will go some use point. I thought all of you know what do you mean by denominator. It is the chosen portion of the fetal presentation which comes in relation with the different quadrant of the pelvis. These are the different quadrant of the pelvis. If you divide by anteroposterior and side to side, there are different quadrants of the pelvis. And denominator relation with the position. So what do you mean by position? Position means the relation of the denominator with the different quadrant of the pelvis. That is, in case of vertex presentation, the occiput vertex presentation, occiput is the denominator, and in the left occiput anterior, or in the left anterior quadrant, and right is the right occipital anterior, right is the right quadrant, occipital. And in case of face and brow, the denominator is mentum, and in case of podalic, it is the breech presentation. It is the chosen portion. That chosen portion is the sacrum, the left sacrum, right sacrum, left sacrum. So these are the different denominators. So these are the different presentation, and also about the denominator, and also the what is the attitude, the position. And now what is the attitude? Attitude is actually the relation of the different parts of the pelvis, different parts of the fetus. Attitude is the fetus. Attitude may be the flexed attitude, that is the attitude may be the flexed attitude, attitude may be deflex attitude, different attitude, different the extended attitude. So these are the different attitude of the fetal head. Attitude is the different relation of the fetal part, that is called the, as it is the, in fact it is the adaptation of the fetus inside the uterus, adaptation of the fetus, the comfortable adaptation of the fetus. Usually normally is the flexed attitude. Now 2 points you must know, what is the sinciput and the occiput. Sinciput is the forward region and occiput lies on the occiput lies in the occipital region. The sinciput and occiput. These are the 2 poles. These 2 poles have value. Value means these are when you are in the grief, when you are doing the obstetric grief, now the different first pelvic grief and second pelvic grief, whether you will which grief you will see, that is the sinciput lies on the, that is sinciput lies on the fetal hands with the on the limbs, and occiput lies on the fetal back. So you will determine the which one is the occiput and which one is the occiput and which is in the sinciput. Which one is the occiput and which is sinciput by the lateral pelvic gift. That is the lateral pelvic gift. You can see there. And engagement also you can see if the occiput and sinciput are not palpable, that they engage, and the occiput not palpable, and sinciput also only palpable, that the part engaged, and when both in the same position, that is the same line, that is the deflex attitude, and occiput below it is the flexed attitude, sinciput below it is the extended attitude. So attitude can be determined. The that is the engagement can also determined by the pole, by the 2 different poles. Now come to the pelvis. The different part of the pelvis. You come to the pelvis. Now first question you are asking the pelvis. The hold the pelvis in the anatomical position. You see when that is the important first question you will usually encounter. You hold the pelvis like this, and with the angle of inclination. You see, hold the pelvis by one hand, left hand, with the ischium, keeping the index and middle finger and the obturator foramen, and the thumb behind the ischium slide medially, like this. You see, this is the anatomical position. Next question is, how will you hold the anatomical position? It is a hold in anatomical position. That is the pelvic brim makes an angle of 55 degree with the horizon. So that is the pelvic brim. And I have seen many students who say they cannot say what is pelvic, or they cannot utter the term the pelvic brim. They say the pelvis makes an angle of 50, but pelvic brim you will have to say. And the anterosuperior iliac spine and the symphysis in the same coronal plane, that is in the same coronal plane. So that is actually the anatomical position. Now next question is what are the different parts of the pelvis? One is the ilium, other is the ischium, and the sacrum and the coccyx. And there are joints on the symphysis pubis, sacrococcygeal joint, sacrococcygeal joint, and sacroiliac joint. And these joints have different roles. That I will come if I get time today. I will describe. Otherwise, on the latter date we will go. There are so many good effects of the role of the joints. Now the pelvic inlet. You describe the pelvic inlet. Pelvic inlet in case of gynecoid pelvis is almost round. You can see it is almost round. Only slight posteriorly depressed by the sacral promontory. That is the pelvic inlet, and it has anteroposterior diameter, oblique diameter, and also oblique diameter, also transverse diameter. Now it is asked in the exam what are the anteroposterior diameter of the pelvic inlet. Anteroposterior diameter, you say the 3 diameter. One is the anatomical conjugate, but true conjugate. Other is the obstetrical conjugate, and another is the diagonal conjugate. Anatomical, the posterior line actually, posterior points lies in the sacral promontory. The obstetrical conjugate and the diagonal conjugate anterior point doesn't lie on the inlet. But you will have to describe the 3 anteroposterior diameter. The true conjugate means sacral promontory to the upper border of the symphysis pubis. True conjugate, it is the 11 centimeter, and it is anatomically important. That is the true conjugate. That is anatomical conjugate. And obstetric conjugate from the sacral promontory to the posterior surface of the symphysis pubis. Posterior surface of the symphysis pubis, middle point and the midline. The middle point means that is the most projected point. The most projected midline. So why projected? Because it is obstetrically into the minimum diameter, usually the 10 centimeter. Minimum diameter, there is the obstetrician headache, and the minimum diameter to be traversed by the fetal head, obstetric conjugate. So anterior point of the obstetric conjugate is the situated on the posterior surface, midline, and the most projected. That is the obstetric 10 centimeter. A diagonal in conjugate is the sacral promontory to the lower border of the symphysis pubis, and the sacral promontory on side and the lower border of the symphysis. It is 12 centimeter. It is important in case of clinical. This is the only diameter we can measure by the PV examination by pelvic assessment. When if you get the sacral promontory, you take like this sacral promontory, palpate it, and after introduction, and then you mark it. This is the that is the diagonal conjugate. It is normally 12 centimeter, but normal condition, good gynecological pelvis, the sacral promontory is not palpable. It is palpable either contracted like android pelvis or generalized contracted pelvis or flat pelvis. So, and what are the importances? Clinically important, and by deducting 1.5 to 2 centimeter, you can get the obstetric conjugate. That is the important. So, true conjugate is anatomically important. Obstetric conjugate is obstetrically integrated. A diagonal conjugate is diagonally is the clinical important. Now, the transverse diameter. The different transverse diameter you will see for the pelvic inlet, different transverse diameter. One is the anatomical transverse. Anatomical transverse is the farthest apart point. Farthest apart point is the farthest apart point or the iliopectineal line. Anatomical. And obstetric transverse, the anteroposterior diameter is make it half by the transverse, make it half. That is the transverse diameter, the obstetric transverse diameter. Actually, the fetal head passes through the transverse obstetric diameter because due to the presence of the psoas muscle of the iliac bone, iliac muscle of the iliac bone. And then in another is the oblique diameter. Oblique diameter is sacrococcygeal joint to the iliopubic eminence. Sacrococcygeal joint to the iliopubic eminence. And the transverse, it is the 12 centimeter, the oblique diameter. And transverse diameter, anatomical diameter, transverse anatomical diameter is 13 centimeter, and transverse, that obstetric diameter, is the 1.5 to 1.5 centimeter below, less than the diameter, less than the anatomical transverse. Now, if you ask to trace the inlet, the symphysis pubis, pubic crest, pubic tubercle, upper border of the superior ramus, iliopubic eminence, and the iliopetrial line, sacroiliac joint, ala of the sacral and sacral. This is the basic questions is usually asked. Now, the pelvis has the two parts. Actually, the false pelvis and the true pelvis. False pelvis lies above the sacral promontory, above the pelvic brim. The only function is the support the gravity. And true pelvis actually there is a play during the labor, the true pelvis, which lies below the pelvic brim. And the pelvic outlet is actually anatomical outlet. It is formed by the two triangle. Is the two triangle. One is the anterior triangle and is the posterior triangle. Anterior triangle and posterior triangle, and divided. The common line is the bituberous diameter, which is usually 11 centimeter. An anterior triangle, and this is the posterior triangle. And the outlet anteroposterior diameter is the lower border of the symphysis pubis to the tip of the coccyx. Normally, its length is 11.5 centimeter, But during second stage, what happens? It is deviated. During second stage, as the sacrococcygeal joint is the mobile joint, and transverse diameter is definitely the bitibial diameter. And now to the plane of least pelvic dimension. Plane of least pelvic dimension. It is the anteriorly lower border of the symphysis pubis, and laterally by the two spines. You can see by spinal, there is two spine and ischial spine, and posteriorly it is the tip of the fifth sacral vertebra. This is the plane of least pelvic dimension. So lower border of the symphysis pubis, ischial spines, and tip of the fifth sacral vertebra. But we know in case of uh, uh, to form a plane, usually the 3 points the plane can go, but may not be fourth point. So that is plane of least pelvic dimension, not a single plane. That is the concept of the mid pelvic plane. Mid pelvic plane is the lower part of the symphysis pubis, ischial spines, and the point, and when it touches posteriorly, it may touch in the S4 S5 junction or tip of the fifth sacral vertebra. If it touches the tip of the fifth sacral vertebra, then the plane of inlet and the plane of inlet is same as the plane of plane of least pelvic dimension is same as the mid pelvic plane. So same as the mid pelvic plane. There are some controversy of the definition of the mid pelvic plane of the plane of least pelvic dimension, but you know the PLD, lower border of the symphysis pubis, the ischial spine, and the tip of the fifth sacral vertebra. The importances are that this is the minimum, that is the narrowest pelvic plane due to the bispinous diameter, which is 10 to 10.5 centimeter. Narrowest pelvic diameter. And anterocostal diameter of the lower border of the symphysis is the tip of the fifth sacral vertebra. It is actually the 11.5 centimeter. And the other narrowest pelvic plane, it is the narrowest pelvic plane. Second is the station is judged in respect to the ischial spine, and the forceps is given in respect to the ischial spine, and the the levator attachment occurs here. So internal completion of flexions here only due to the levator muscle, and also the internal muscle starts here. Another important for the giving the pudendal block, the pudendal nerve hooks the ischial spines, and deep transverse arrest occurs in the. So these are the various importance of the plane of least pelvic. Another thing is the what is obstetric outlet. This question is asked. Obstetric outlet is actually, it is the area segment of the pelvis, bounded below by the anatomical outlet, and above by the plane of least pelvic dimension, or by the plane of least pelvic dimension. Anteriorly it is deficient, posteriorly is the coccyx, and laterally the ischium and ischium bone. This is the thing. And what is the posterior sagittal diameter? Posterior sagittal diameter is that part of the diameter which lies of the anterocostal diameter posteriorly sected by the transverse diameter. Like in case of plane of inlet, the posterior sagittal diameter 5 centimeter, plane of least pelvic dimension 5 centimeter, and plane of outlet, that is the gynecological or anatomical outlet, is 8 centimeter. The posterior sagittal diameter is very important because for the rotation of the pelvis, the rotation of the fetal head, the posterior sagittal diameter should be sufficient. Now, what is the angle of inclination? Angle of inclination, I have already said, the angle of inclination is the 55 degree. And another angle of inclination with the sacrum, first and second sacral vertebra, with the lumbar vertebra, it is 135 degree centigrade. 135 degree. And the sacrum is normally it is the concave, side to anteriorly, side to side, and more on the above downward. And sacral angle is the angle between the S1 and S2 with the pelvic inlet, which should be 90 degree or more. But in case of android pelvis, it is less. That is the less space in the less space in case of for the rotation, particularly the android pelvis. And the pelvic inlet can be subdivided in the gynecoid pelvis, flat pelvis, lateral, side to side, and anteroposterior short, that is short in case of flat pelvis, but anthropoid pelvis, it is anteroposteriorly larger, anteroposteriorly larger. And anthropoid pelvis, that is the problem is the more occipito-posterior, and transverse pelvis, that is the flat pelvis, that is the platyploid pelvis, that is the inlet. There may be problem in the inlet, and then there is the no problem. Android pelvis, there will be arrest in the inlet and the mid pelvis and the outlet. So these are the three types of inlet pelvis, and these are also differs in the different inlet and also the outlet and the pelvic cavity. Now only I will think the time is almost over, so I am just one thing, how to do the pelvic assessment. The one is the 2 minutes, 1 to 2 minutes. Pelvic assessment, that the Mularkar method, that is the bimanual Mularkar method, that is it is done. Pelvic assessment, that may be the cephalopelvic disproportion on one thing. If you try at the term or at the early labor, you try to push it. And the thumb above the spine. If it goes at the level of the spine, so there is no disproportion. You just touch, there is a borderline disproportion, and it deflects, that is the severe disproportion. And borderline disproportion, there is a chance of borderline disproportion, there is a chance of trial labor. And when the lower pole touches the ischias bispinous diameter, it means it will engage, because from the circumference to the lower pole of the head, it is the only 3 to 4 centimeter, but here it is 5 centimeter from inlet to and for pelvic assessment by PV examination, you assess the posteriorly the sacral curvature and the tip of the that is the sacral promontory, and laterally ischias spine, whether it is ischias spine, sacrosciatic notch is important, and whether they are parallel to each other. And outside you come to the, that is the PV. So inside the bispinous diameter you also see. Normally you cannot do with this finger. And pubic arch, there is the pubic arch and subpubic angle. Subpubic angle is usually 90 degree or more. It may be 85 degree or more in different opinion. The subpubic angle, and this is the bituberous diameter, that by the proximal joints or by the knuckle. Bispinous diameter is measured. Like this. And what is the waist space of Morris? Waist space of Morris, if one disc is placed in the outlet, so there is a gap in the lower bottom of the symphysis pubis in the circumference. That should be 1 centimeter or less. If there is a more than 1 centimeter, then that will be there. The outlet diameter, outlet will be short. That is the problem of the delivery. I think the other parts of the pelvic joints, I will say another session, Ashish, and other details of the abnormal pelvis and the pelvic joint in another session will do. So this is, I think, today.
Thank you so much.
Thank you all for giving
Thank
me.
you, Arupda. Thank you very much. Yeah, Arupda has gone too much of basics. Maybe he has gone into the undergraduate zone, because perhaps Hafizur has requested him to go into basics.
That is why.
Basics. Just I wanted to add whatever Arupda has said. Denominator, when you have gone up to the level of denominator, the postgraduate level, they should know why the denominators are arbitrarily called selected. Denominators are never fixed points. As you said, the chosen points. Chosen portion. Not the point. Important point for the postgraduates to know is that the denominator may not always be a part of the presenting part.
Occiput.
That is and that is one thing that
Occiput is the exception.
Yeah. So that is why it is called the arbitrarily fixed bony part. Anyhow, there are a lot of discussions which can go on. If you start from the undergraduate level, there are a lot of discussion. But I think that the postgraduates
Yes.
sometimes are asked our questions and other things also. Like he has touched upon the syncretism, asyncretism, the what is anterior asyncretism, what is posterior asyncretism. These things they might be asked. So I think that we will keep at that because we'll go on reviewing the dummy fetus pelvis time and again every time we discuss this because this is a very important thing. And the students are always confused with this issue. So time and again we will pick up one issue and we'll try to solve them. It is not possible
Yes.
to have everything together.
Not a single lecture, single.
Thank you very much,
Yes.
Aruna, for being very basic and opening the basic Pandora's box in the for the postgraduates. Yes, sometimes now that this designated session has 10 marks in postgraduate examination, I think we need to know the basics or rather recapitulate the basics.
Yes.
I will not say the students will not read the basics. Thank you very much, Aruna.
Thank you, thank you.
Thank you, sir.
I think
Thank
we
you
will
so
take
much,
another session for which have already done previously.
Yeah.
The
Thank you
joints and
so
the
much,
pain-
Madhu, for your excellent demonstration. As well, it shows your passion for teaching, and we are thankful to you. And I am sure the students will greatly benefit from you. The program will be in the record also in the ICOG website, so the students can later on view to go again and again. As Ashish sir said, we will have open in different aspects. Maybe we'll have repeated in some sessions. And in one way, the students are fortunate these days. They can have so many access of this demonstration that they could see these days. So I'm sure this will be very much helpful to this. And I'm again thankful to you, Mazi sir. We'll have you again and some other aspects of this demonstration.
With a very short
So,
period of time.
without-
Short notice you have. Only few days back
Yeah.
you have asked me
we will
to.
take some aspects of just like way we are taking in different ways and different parts, different techniques for demonstration, and those are really helpful. So, Maji sir, if you are there, I would like to request you stay back. If you are there, thank you so much, sir. I will move like to our second session, that is on case discussion. So for this month, we have an important case on primary amenorrhea. And the students are from All India Institute of Medical Science, Nagpur. And Dr. Deepika Yadav and Dr. Shalini Dange will present the case. And they have been amply guided by their faculties, Dr. Amruta Chaudhary, Assistant Professor at AIIMS Nagpur, as well as I'm thankful to their HOD, Dr. Suchita Munle, and another faculty, Dr. Anita Yadav, for having their students and guiding to them to this national platform. I would like to wish them all the best, and I would like to request our faculties, Professor Dr. Ashish Kumar Mukhopadhyay sir is there for a constant support in every program. Sir is principal professor at CSS College of OBGYN and Child Health at Kolkata. Then we have Dr. Pranay Fukan. Sir is professor and head at Assam Medical College, Dibrugarh. We have with us Dr. Karthika Prabhu. Madam is professor at SRM Medical College and Hospital, Chennai, Tamil Nadu. We have with us Dr. Naina Kumar. She's an additional professor at AIIMS, Bibinagar. Then we have another experienced faculty, Dr. Anuradha Panda. Madam is senior consultant at Apollo Health City, Jubilee Hills, Hyderabad. So I would like to request Dr. Deepika Yadav and Dr. Shalini Dange to start sharing their presentation. And at the same time, request our faculties, Dr. Ashish Mukhopadhyay, Dr. Karthika Prabhu, Dr. Pranay Pupansar, Dr. Naina Kumar, and Dr. Anuradha Panda to take over from their ends and ask the question as well as take their case on primary amenorrhea. And I'm sure it will be greatly helpful to all the students for covering the primary amenorrhea, how they are asked in the examination when they're faced. Over to you, all of you, sir and madam. Ashish, sir, and
Yes, I think the presenters are Dr. Deepika and Dr.
Shalini
Yes.
Dange, sir.
Shalini. Okay.
Yes, sir.
So I am sure Dr. Kartika Prabhu Madam and Pranay Phukan sir, Dr. Naina and Dr. Anada Pandam. Welcome you all.
Thank you, sir.
Welcome all the faculty members. Okay.
Thank you, sir.
Let us see them presenting the case first.
So shall we proceed,
Sir,
sir?
Yes, you start.
yes, sir. I feel they can quickly present, then can go back to their slides and the way you all of the faculty can. Yes, please go ahead. Over to you.
Good afternoon, respected faculties. Myself, Dr. Deepika Yadav, JR3 in the Department of OBG, AIMS Nagpur.
Myself, Dr. Shalini Dange, JR3 in the Department of OBGY, AIMS Nagpur.
Today, we are presenting a case on primary amenorrhea. My patient is 19 years, unmarried girl, resident of rural area, currently pursuing her graduation, belonging to lower middle class, presented with chief complaint of not attaining menarche, excessive hair growth over chin and face, and hoarseness of voice since the last 4.5 years. She was apparently all right till the age of 13 years. Then she started noticing excessive hair growth over face and chin. Hair growth was present in the axillary and pubic region, but there was no hair growth on the chest and the anterior abdominal wall. This was followed by hoarseness of voice at the age of 14 years and not attaining menarche. She did not complain of cyclical abdominal pain or any urinary difficulty or retention or bowel disturbances, ruling out the possibility of conditions related with cryptomenorrhea like transverse vaginal septum or imperforate hymen. She did not complain of excessive acne, weight gain, or darkening at the back of the neck, ruling out the possibility of any metabolic syndrome or conditions like polycystic ovarian syndrome. There's no history of any visual disturbance, headache, nausea, vomiting, or galacturia, ruling out the possibility of hyperprolactinemia or prolactinoma. There is no history of hearing loss or decreased sensation of smell. These conditions are seen in some of the syndrome associated with primary amenorrhea, like hearing loss can be seen in Perrault syndrome and Turner syndrome, and decreased sensation is associated with syndrome like Kalman syndrome. There's no history of vigorous exercise, decreased appetite, chronic starvation, or malnutrition, ruling out conditions like chronic stress or bulimia or anorexia nervosa. And there's no history of any weight loss or heat intolerance, ruling out any thyroid disorder. There's no history of hot flashes or mood disturbances, ruling out a hypoestrogenic condition. There's no history of fever, so the possibility of infectious condition of primary amenorrhea is ruled out. And there's no history of trauma to the head or intake of any neuropsychiatric medication. In past history, she has no history of any major medical or surgical illness. However, she gives history of taking some hormonal treatment from private hospital for amenorrhea in the year 2021 at the age of 15. These medications she took for around 3 to 4 months, for which the details are not available. In family history, her mother is 45 years of age, and she gives history of normal age of menarche, and my patient has no siblings. In personal history, she has no addiction and there's no history of any sexual contact. Nutrition history, my patient consumes on an average of 1500 kilocalories with a deficit of 300 kilocalories per day, and her daily protein intake is 35 to 40 grams, which is normal for her age. In birth and developmental history, her mother gives history that patient was delivered via vaginal delivery and there was no ambiguous genitalia at the time of birth. Her height and the weight growth patterns were normal over the years, and she achieved her neurological milestones normally, and she had good scholastic performance. The onset of breast development and pubic hair development was approximately at the age of 13 to 14 years. On general examination, patient is conscious, well-oriented to time, place, and person. Her height is 161 centimeter, weight is 41 kg, making BMI of 15.8 kg per meter square. So the patient falls under the underweight category. Vitally, she was stable with BP of 90 by 60 mmHg at the time of presentation. On head-to-toe examination, her hair was normal. There is no pyloric teres. Orodental hygiene was well maintained. Excessive hair growth was noted on the chin and face. Along with this, there was growth of hair which was seen over the upper and the lower abdomen. over the inner aspect of the thigh, upper back, and the lower back, making Ferryman-Galway score of 70, which falls under the category of moderate hirsutism. There was no webbing of neck or carrying angle was normal, ruling out the possibility of condition like Turner syndrome. There's no thyroid swelling, spine was normal, and the gait of the patient was also normal. On breast examination, a slight elevation of the breast tissue was noted, that is breast bud stage, making Tanner stage of breast development stage 2. And on pubic hair examination, there was coarse, pigmented, curled hairs seen over the pubic area, but not over the inner aspect of the thigh, making pubic hair development as Tanner stage 4. On systemic examination, heart sounds were normally heard. There was no murmur. On respiratory examination, bilateral air entry was equal and no adventitious sounds were heard. On CNS examination, patient was conscious, well oriented to time, place, and person. Gross sensory and motor examination is within normal limit. On inspection, abdomen appeared normal contour, umbilicus was central and inverted, no evidence of visible lump or scar mark or engorged veins was seen, hernia sites appear intact and no obvious swelling was present, especially in the inguinal region. On palpation, abdomen was soft, non-tender, no organomegaly or evidence of the mass was seen. Tympanic node was heard over the abdomen, there was no free fluid and vowel sounds were present normally. On local examination, clitoromegaly was noted of around 1.5 to 2 centimeter. Mid-clitoral meatal opening was seen. Labia majora appeared fused. Gonads were not palpable and there was blind vaginal pouch which was present. And on perrectal examination, uterus and cervix was not palpable.
To sum up the case, my patient is a 19-year unmarried girl with primary amenorrhea, with hoarseness of voice, with features of hyperandrogenism, having a Ferryman-Galway score of 17. She falls under underweight category with a BMI of 15 and has a Tanner stage of 2, pubic hair Tanner stage of 4, with clitoromegaly, fused labia majora, no gonads were palpable, with blind vaginal pouch. So my provisional diagnosis is a 19-year girl with primary amenorrhea under evaluation, most likely an androgen insensitivity syndrome. And my differential diagnosis are androgen insensitive syndrome. It could be complete or partial. Oxidase deficiency, mixed gonadal dysgenesis, or it could be a congenital adrenal hyperplasia. Sir, shall I proceed with the evaluation, sir?
Proceed with the evaluation also.
Yes, sir.
You will start with the present slide only.
Yes.
Don't change the slide now. Yes.
Okay, sir.
Okay.
Your provisional diagnosis was androgen insensitivity syndrome.
Yes, sir.
And then the differential diagnosis also you have written androgen insensitivity syndrome. So
Yes,
diagnosis cannot be both provisional as well as differential, isn't it?
Why do you think it is complete? Any points in favor of complete androgen insensitivity syndrome?
Ma'am, it is more likely a partial androgen
And
insensitivity.
you put
syndrome,
complete as first. That's why I'm saying.
Yeah, keep partial only,
Keep
but
partial.
remove it from the differential diagnosis. If your provisional diagnosis is that, you can justify that, but remove it from the differential diagnosis. Okay.
Yes.
Now, going back few slides, I saw that there are some places you have mentioned about the sensation of smell and other things you have mentioned, history. Go back
Yes,
to
sir.
that slide.
Yes.
And while describing that feature, that history, you were saying that it could be a feature of, hypothalamic amenorrhea, Kalman syndrome, etc. While presenting a case, do not say all these things. The examiner knows what you mean, isn't it? So
Yes,
if you say that, then what will happen? Your flow of presentation will be affected, and the examiner will now discuss about the hypothalamic amenorrhea and Kalman syndrome and all those things. You understand my point? Do not
Yes, sir.
deviate the case presentation. Go in a linear fashion. Okay, so these two things apart, I think you said something about the protein intake per day according to our age. Is the protein requirement age dependent or the body weight?
So it is body weight dependent.
Okay, so these are the things that you need to mention about, in detail. Now the crossing starts. Yes, madam. I think madam was asking you about the differential diagnosis. Another madam.
Yes, sir.
Asking.
So you put it as complete first.
Hmm.
Anything for and against your complete androgen insensitivity syndrome?
Yes, ma'am. My patient has ambiguous genitalia, ma'am, and has a pubic.
Incomplete. Okay. Yes. Okay. Ambiguous
Yes.
genitalia. Then.
And my patient also has pubic hairs and sparse axillary hairs, ma'am.
Now,
So
PB
it
is
favors more of
for the
partial.
point, for or against the point, complete variety.
It is against the point, sir.
Against the point. Yes.
Yes.
So you're more in favor of partial. So you should
Partial.
complete in the beginning. Yeah. You can otherwise put it as androgen insensitivity without writing partial or complete. Then you can explain. Okay.
Yes, ma'am.
Then what are the other provisional diagnoses?
And we have 17-alpha hydroxylase deficiency, mixed gonadal dysgenesis, or congenital adrenal hyperplasia, late onset congenital adrenal hyperplasia, ma'am.
Okay. What is in favor of your late congenital adrenal hyperplasia? You said at birth there was no ambiguous delta. It all started around puberty.
Puberty, yes, ma'am.
Yes, around 13 years it started. That's what you said in history, I think.
Yes, ma'am.
Around puberty it started. Okay. Then what are the other differential diagnoses when it starts around 13 at pubertal age?
70, it could be gonadal dysgenesis, ma'am. It could be androgen insensitivity syndrome, or 17-hydroxylase deficiency, 5-alpha reductase deficiency. Congenital adrenal hyperplasia.
I missed the examination findings. Maybe, Dr. Anuradha, have you seen? Have they mentioned about the palpable gonads anywhere?
They have written, she didn't highlight that, but she said no palpable gonads.
Yes,
I think
gonads are
the
not.
area was free. You said that, na?
Okay.
You should highlight actually. That is something you just passed off. No swelling or something you said. That you should highlight that you didn't find anything in the inguinal region.
Yes,
And the
ma'am.
hernial orifices?
Are free or did you find any?
No, ma'am. There was no mass palpable at the hernial
Okay.
sites, ma'am.
Okay.
So gonads are not palpable. It may not be palpable also.
Yes, ma'am.
Maybe
Yes, sir.
it doesn't make much difference. But if it is palpable, you must write that. Okay.
Yes, sir.
So what are the
Suppose
possible, other possible diagnoses? And madam was asking about the late onset CAH. What are the features of late onset CAH, congenital adrenal hyperplasia?
There will be hoarseness of voice, features of hyperandrogenism will be there, sir. There will be hirsutism.
There are features of virilization, like clitoromegaly will be there. There will be excessive hair growth. Associated symptoms could be like salt wasting symptoms. Sir.
Okay, that is the severe variety. Normally, late onset doesn't show that.
Usually it's confused with a polycystic ovarian syndrome. That's important. A late onset may be confused with a PCO patient who has a lot of hair, hirsutism, and yes.
Now tell us one thing. Do you think that the excessive pubic hair that you have seen in this case, isn't it? You have said that the pubic hair is excessive. Is it a feature of virilism or hyperandrogenism, or it's a type of normal growth and development of the pubic hair? What do you think?
Sir, you're talking about pubic hair distribution, sir?
Normal pubic hair distribution.
Yes, sir.
She has normal pubic hair distribution, sir.
Okay. Normal pubic hair distribution doesn't go in favor of androgen insensitivity syndrome. Okay. But yes, it can be hyperandrogenic features virilized. It can be so. So, particularly the incomplete variety or the partial variety. Okay. So, anything else that you can clinically exclude or clinically consider other diagnoses? Dr. Pranay Fukan, are you there?
Suppose this patient is not having hyperandrogenic features, he is having only a blind vagina. What else can be the differential diagnosis?
Ma'am, it could be Mullerian MRKH syndrome.
Going to differentiate MRKH syndrome from androgen insensitivity syndrome?
Ma'am, we can do karyotyping, ma'am. In MRKH,
No,
there will
clinical
be
examination. Examination
On
wise.
clinical examination, ma'am, it will be the development will be like normal phenotypic female, ma'am. There will be no features of any hyperandrogenism. Like androgen insensitivity syndrome, ma'am.
Dr.
So
Pranay, you
presence of
want to ask
pubic hair.
something? Dr. Kartika, it is no? Who is asking question? Dr. Kartika.
Ah, yes, ma'am. Yes, sir.
Kindly make yourself visible, please. We can't see you. Oh, yes. No.
Hello.
The presence of pubic hair is a feature. It will be present in case of MRKH syndrome, whereas in case of androgen insensitivity syndrome, there will be no pubic hair or stars.
Yes, ma'am.
So what? Hello.
Yes,
Yes,
yes.
Dr. Pranay. Yes, tell us.
Yeah. So that clitoribegally, can we just differential other differential diagnosis clitoribegally is there?
Yes, sir.
Clitoribegally, can it be differentiated to some other conditions besides CH? Hello.
They are asking for different conditions where you can see clitoromegaly.
Yes, sir. Yes, ma'am. There could be condition like androgen insensitivity syndrome. There could be congenital adrenal hyperplasia in conditions like androgen secreting tumors. There could be condition like 17 alpha hydroxylase deficiency or 5 alpha reductase deficiency. And so in some iatrogenic conditions where the patient is taking exogenous testosterone, androgen
secreting tumors.
Okay.
So further investigations what you're going to do with this patient?
For this patient,
Sir, we have done the imaging, sir. We have done the abdominal pelvic USG. In that, there was no absent Mullerian structures, and there was presence of bilateral inguinal gonads, which was then confirmed with the MRI pelvis. Bilateral kidneys and adrenal glands were normal. Then we have done the hormonal profile of constituting LH, FSH, estradiol, testosterone, and thyroid function. In that, we have noticed there is a increased LH and FSH levels and decreased estradiol levels less than 5.0, and testosterone level was 385.4 nanogram per deciliter. Then we have done the karyotyping. It was 46XY. And then to differentiate between CAH and 17-hydroxylase deficiency, we have done the stimulation test, sir. We have seen the baseline cortisol level at 8 a.m. in the morning. It was 10.1, and after stimulation, the cortisol level was increased to 20. And after ACTS stimulation test, we have measured at 30 minutes and 60 minutes 17-hydroxyprogesterone levels. Both came to be normal, which rules out 17-hydroxylase deficiency, sir. This is the flowchart that how we proceeded with our patient.
Go slowly a bit, okay? You're moving too fast. Go back to the previous slide.
Yeah.
Yes, sir.
Yeah. What do these two tests suggest? Other tests.
Yes, sir. After ACTH stimulation test, the baseline cortisol, if it increases, then there is a functioning 21-hydroxylase enzyme. So this rules out congenital adrenal hyperplasia, sir. Then after ACTH stimulation, we have to measure at 30 minutes and 60 minutes 17-hydroxyprogesterone levels, sir. If it does not, if it is in the normal range, or if it is in decreases, then this rules out 17-hydroxylase deficiency.
Okay. So essentially, these enzyme disorders have been
ruled out. Yes, sir.
Okay. The karyotype is 46XY.
Yes,
so what
sir,
is the diagnosis now?
Sir, what is?
Would you like to go
Sir,
to
can
the
you please?
flowchart?
Yes, sir, flowchart.
Go ahead then.
Yes, sir. Yes, sir. My patient, she has a primary amenorrhea with hirsutism with hoarseness of voice, with breast anal staging 2, Ferryman Galvez score of 17, ambiguous genitalia and karyotyping of 46XY. My differential diagnosis are AI, androgen.
Slowly. You go slowly, please.
Partial, yes, sir. Sorry, sir. Partial androgen insensitivity syndrome, congenital adrenal hyperplasia, 17 alpha hydroxylase deficiency, or mixed gonadal dysgenesis. As my patient has normal testes and there is high level of testosterone, this rules out mixed gonadal dysgenesis. In this, there will be streak gonads or it will low testosterone levels, ma'am. So we have.
1 minute. We'll go back to the testosterone level, please, first.
Yes,
Go
sir.
back to
It
the
was
slide
385.
showing. It is showing the testosterone level. Yes, this one.
It was raised, sir.
That is in the male range, isn't it?
Yes, sir. Male range.
385.4.
Yes, sir.
TSH is normal and TCT4 are normal. Estradiol is too low and serum FSH is very high. Hypergonadotrophic, 43.4 and 143.5. Go to the
Yes,
previous
sir.
slide. Previous to this,
Previous.
we have another
We
slide.
have imaging.
Oh, imaging. Yes, imaging. Yes.
Yes,
What was the
sir.
imaging report? MRI about the structure and structure of the testis. They have mentioned something.
Yes, sir. They have mentioned it is small size, sir. 1 into 1.5 centimeter on the right side and 1 into 1.4 centimeter on the left side.
Good. Okay.
Okay.
Small ovoid. But are the sizes normal? How can you say that these are normal testes?
Sir, palatal gonads were present, sir.
Palatal gonads were present, but the size was slightly small, sir.
Okay. Since the testosterone level is normal in the male range, you can perhaps say that, yes, they are normal. So now come back to the original slide that we were discussing.
But is it clear they are undescended because they are written in subcutaneous plane? Something they have written in that scan. They are
That's what I
undescended.
wanted to see.
Subcutaneous should be palpable, no? If you.
That
It
is what
subcutaneous,
you
it should be
said.
palpable.
They are not no gonads you were able to palpate, but here it is written noted in subcutaneous plane in bilateral region. Where? It is not clear in that.
Where is it written? Oh yes, subcutaneous plane in the bilateral.
Plane in bilateral regions. Which region? They have not clearly. Were they undescended testes?
Yes, ma'am, they were undescended testes. It was found later that they were present at the deep inguinal ring, ma'am.
Deep inguinal ring.
Yes, sir.
Deep inguinal ring, very much the possibility of undescended testes is there.
But they were not palpable.
They were not palpable, ma'am.
Okay. Okay. Have you examined for the undescended testes? I mean, palpable gonads. Have you done that?
Yes, sir. In inguinal region, it was not palpable, sir.
Okay, so it suggests absent uterus fallopian tubes, blind ending vagina, normal bilateral seminal vesicles, bilateral inguinal testis. Above imaging features of partial androgen. Okay, go back to the original slide, our discussion, slide discussion.
Yes, sir.
So yes, we accept that there are functional gonads present.
Yes,
ACP
sir.
stimulation test have shown the result. Not a
Yes,
case
sir.
of the late onset congenital adrenal hyperplasia.
Yes,
So
sir.
the diagnosis stands now as partial androgen
Yes.
insensitivity syndrome,
Yes, sir.
isn't it? How
Yes,
old
sir.
is she now? How old is she now?
19.
Yes,
19.
21
years.
21 years.
21 years. Okay.
Presentation, she was 19.
So dealing with the case of partial AIS, external genitalia is ambiguous. You can say that because she has, although she doesn't have hypospadias, but she has
Phallus
phallus.
Yes, sir.
It is already managed.
Why do you say pubic hair
Yes,
reduced?
She's managed.
No. Why do you say pubic hair is reduced? Pubic hair was there, no?
No, sir, pubic hair were 10 at stage 4, sir.
Okay, I'm getting a bit confused.
Actually, it looked normal.
Yes, ma'am,
it was normal.
Okay. Anyhow, let us accept the diagnosis of partial AIS.
Yes.
Management, you don't have to show the slide. Okay, you stop the slideshow now. You can come back to the original this thing, and keep it there. So, what do you propose to manage now? This girl, this unmarried girl. When I say girl, it is obvious that she has been reared up as a girl, right?
Yes, sir.
Have you inquired about the sex of rearing of this girl?
Yes, sir. We have consulted with the psychiatric department also. So as she was reared as female, sir, she wanted to continue as to be a female.
I think sex of rearing should be started with the parents.
Parents, yes. You should have asked parents.
Now the girl is old enough. She has a decision also.
Yes.
1920.
Yeah, that is true. But even then, the sex of rearing, when she was small, I think the parents should answer that whether they found any features like a hoarseness of voice or something like that, or a male type of behavior or something like that. Did they notice that, or they reared up naturally as a girl? That history is important.
Yes.
Dr. Pranay, I want your input here. And Dr. Anuradha, yes.
Yes, sir. Now, when she was 13, I think she was not old enough. That time, parents should have been asked when she had hoarseness of voice and she had the hirsutism. But now I feel when she's 20, 21, she should think her sexuality and psychologists should be counseled. And she should decide whether she wants to be reared as a female as she is being reared or change her sex.
Yes.
If she considers like
What did the child say? Did you first talk to the child and the parents?
Yes, ma'am. They wanted to be reared as female only, ma'am.
Okay.
So how will you approach now?
Yes, how
So
will you?
everyone has agreed to rear her as a female.
Female.
Fine. Now, under the circumstances, what are you going to do? There is a concern also about the gonad. We'll discuss that later. But at the present moment, how do you propose to, make her appear like or feel like or, give them convincing this thing like she can be safely reared up as a female after some operation maybe later on. So something like that. What do you propose now?
Sir, initially, I will like to do her psychosocial education counseling, sir. And then after counseling, we will explain her the risk of malignancy if the cryptotic gonads are there. So after explaining the risk, we'll proceed with, if they're willing for the gonadectomy, we'll proceed with the bilateral gonadectomy with vaginal reconstruction surgery, sir. And then we'll start with the hormonal replacement therapy.
At what age you will go for gonadectomy? If she would have been like 13 years, if she would have been diagnosed with this, with undescended testes and she had these complaints,
yes,
would you still have gone for gonadectomy or any
no,
particular
ma'am.
age is there?
Yes, ma'am. In case of partial AIS, we'll wait till the patient has the secondary sexual characteristics, ma'am. And later, after attaining her secondary sexual characteristic, then I'll proceed for the gonadectomy, ma'am.
Okay.
Now, how do you counsel her? Can it be something like this to the parents that you will be surprised to hear that he's actually a male? Do you counsel like this? Or you counsel using some different languages? We want to hear. How will you counsel the parents and also the girl?
Yes, sir. Sir, we will counsel that the karyotyping is 46XY, but the features are of phenotypically she is a female. So there will be we'll counsel them as there will be no reproductive function in her future life, but sexual function can be attained by doing vaginoplasty, and for clitoromegaly we can do clitoroplasty. Sir.
It is also important to mention that she has been reared up as a
Yeah,
female.
that's female.
Good.
Yes,
So the medical science agrees with your this thing, and we would like to help you all possible support in the direction of female development. That may, a kind of console them. And instead of discussing about the karyotype, because that they won't understand much, but karyotype is important in the sense that the malignancy has to be explained very, very carefully to them, isn't it?
yes, sir.
Basically, these are disorders of sexual development. So instead of labeling him or her as male, female, it's better you can counsel them as disorders of sexual development.
Yeah, if you talk to the parents about DSD, it will be more ambiguous to them. But anyhow, that is the line on which we will talk to them. We'll never mention about the male or female or karyotype or something like that. Disorders of sexual development. Okay.
Do you need to go for hormone therapy subsequently?
Yes, sir. We'll have to go for hormonal replacement therapy, sir.
How do you plan it?
Sir, as she is now 19-year-old, so we'll start with the hormonal replacement therapy. Initially, we'll start with the low-dose estradiol, sir, estrogen therapy, and we should increase it every 6 months over the period of 2 to 3 years. As my patient doesn't have uterus, we'll not add progesterone in them, sir. So presently, she is taking estradiol valerate 1.5 mg OD, sir, once a day.
Dr. Pranav, they were talking about something like the reproductive potential and the sexual life of this girl. So what are you saying? You just tell us once again. What will you tell them? Once you agree to rear her as a female, then obvious expectation will be about the sexual life and the reproductive life. What will you tell them?
Sir, we can counsel them that after some surgeries, it is possible for her to have normal sexual life. But about the reproductive function, we can counsel her it is not possible to have her own biological child, but later on in her life, she can have the option of adoption, or she can have donor egg and can go
surrogacy.
for surrogacy. Sir.
Okay. What type of surrogacy is this? Okay, now come back to the original question by Dr. Pranay Fukan. He has asked about the hormonal thing, therapy in this girl. And by the way, would you like to do the gonadectomy right now?
Yes, sir.
Yes, sir, she's 19 years, so we can do the gonadectomy.
She has achieved the full development of the secondary sexual characteristics to the extent possible.
Yes, sir.
So I think we can go for gonadectomy right now. Okay.
Any condition where you'll go for gonadectomy at an early age?
Yes, ma'am. In case of mixed gonadal dysgenesis, we should go for early.
What is Swyer syndrome? You have any
Yes,
idea? It can
Swyer.
also present with clitoromegaly in rare circumstances.
Yes, ma'am.
Yeah, why not a case of Swyer syndrome? A good differential diagnosis. What are the features of Swyer syndrome?
In Swyer syndrome, sir, the karyotype is 46XY, and there is the gonads are streak, so there is no production of testosterone and AMH. So the patient will have phenotype like a female and will not have Mullerian structures, sir. In Swyer syndrome.
Mullerian structure to यहाँ पे भी नहीं है, but given two cases, the Swyer syndrome and this partial AIS, which one would you prefer?
Sir, I prefer partial AIS.
Why?
Sir, in Swyer syndrome, there will not be a testosterone level increased, sir, that much, because there will be no gonads, or it will be gonads will be there, it will be streak gonads.
Gonads can be there, and even they can have malignancy also. So they can have clitoromegaly also. Only thing is their SRY gene is silent in them, Swears.
If she would have preferred to be reared as a male, what you would have done? You gave her the option, right? If she would have said, I want to be reared as a male, now changing sexuality.
Phallus.
How can we help them?
How could I have helped them? Now she has the, he has the, I mean, she has the testis. You said gonads are there.
And
Yes,
with
ma'am.
fairly
They
high
can
androgen
Yes,
levels.
genitalia.
Very good androgen levels.
Yes.
We can do orchidopexy
Okay.
and
We
androgen
can give
therapy.
testosterone therapy, sir.
Testosterone. Okay. Testosterone is
It's
already
already
Pretty
high.
there.
yeah, it's already high.
And we have to correct the hypospadiasis.
Okay.
Can you expect, healthy spermatozoa from this lady, from this patient for further pregnancy?
Sir, can you please repeat the question, sir?
Can you just, hello?
Yes, sir.
So suppose it's XY, so can you expect to get some healthy spermatozoa for further, pregnancy?
No, sir. No, sir. There will be infantile seminiferous tubules.
Okay.
So there will be no spermatogenesis, sir. So we can't expect a healthy sperms in them.
And these are undescended testes.
You cannot exactly say like that. If you want to, you can go for some, extracts, or they can find sometimes for ICSI and all. You got to say, yeah. Anyway, what is the long-term effect of this patient? What will happen when patient is getting? How long you are going to give the estrogen therapy, and then what will be the other effects subsequently when she will be around 30 plus or 40 years?
She will be given, sir, hormone replacement therapy till the age of around 50, sir.
Considering that will be the normal age of
menopause. And long-term effects we can have is there could be increased risk of thromboembolic events. Then there is risk which are associated with long-term estrogen use, like cholestasis or possibility of gallstones. Then there could be
risk
What
of
will be the
breast
effect?
malignancy.
What will be the effects of the bone?
So
There
there
could be
decrease in the
decreased
bone
bone
density.
mineral density, so we have to add calcium and vitamin D supplementation along with the therapy.
All right.
Dr. Naina Kumar, Dr. Karthika, would you like to come out with some questions to the students?
If this would have been MRKHS, do you have any other option, future option for fertility other than surrogacy or adoption? If there would have been no clitoromegaly, there would have been a rudimentary or no absent uterus, blind vagina.
Ma'am, they can have the IVF by oocyte preservation, and then they
But
can
they
opt
don't
for
have
C.
uterus, so IVF, how come?
No, ma'am, IVF with the oocyte retrieval, ma'am,
and then go for
IVF, how it can be a possibility.
Have newer things, no? You give them an opportunity. What will you do?
And
Anything else
if
you can do?
they don't want to go for surrogacy or this adoption, any other recent thing is there they can go for?
Uterine transplantation.
Yes.
Hmm.
Oh, uterine transplantation for that.
They are candidates for uterine transplantation.
Suppose patient wants vaginoplasty. So what age you would like to do that?
Ma'am, we like to do when the patient is planning to get married, ma'am, or whenever they want to have a sexual function. Before that, we should.
Before marriage, it's not, yeah. How many months before marriage or sexual contact? Why is it important? You can do even, I mean, will you do at 19 year, 18 year or 13-year-old? Why it's important that it should be before her marriage or when she understands how to maintain the vaginoplasty? Why is it important? What do you have to do?
Yes, ma'am, there is a risk of fibrosis.
And
What do they do? What is told to them after surgery?
Ma'am, they have to do regularly vaginal dilation.
Yes.
Dr. Naina Kumar, do you have any questions for the students?
No, sir.
What are the
Okay.
various approaches by which you can do vaginoplasty?
Is there any chance of gynecomastia in these patients subsequently? That what do you do for that?
Only when they are going towards the male development, right, Dr. Pranay?
Yeah, yeah.
Okay. If the sex of rearing is male, then probably they have to deal with this gynecomastia also.
What are the methods of doing the vaginoplasty? The common
There are non-surgical methods, ma'am, and the surgical method. The non-surgical method is the Frank's or the Ingram's method, ma'am, in which the patient uses vagina dilators at the point of the vaginal dimpling. Then there are surgical procedures like the McIndoe's procedure, in which in this procedure we dissect the rectovaginal space, and then a skin graft is placed over the soft mold, which leads to the formation of the neovagina. Then there are other procedures like the Vichetti procedure, ma'am. In this, we approach abdominally and vaginally by resecting the vesicorectal space, and a traction device is kept abdominally, giving traction to the vaginal dimple so that a new vagina is created. Then there are the procedures like intestinal vaginoplasty, where a part of the
surgical methods are there.
Yes, ma'am.
Intestinal
Better
vaginoplasty.
methods which can be even done laparoscopically. More
Ma'am,
simple.
modified version of Vichetti's procedure, ma'am.
What is that called? Modified Vicchetti. Okay, what is that called? Have you heard about Davidoff's vaginoplasty?
Yes, ma'am. Davidoff. In that, in Davidoff procedure, ma'am, peritoneum from the posterior from the pouch of Douglas is used to create a new vagina.
Any other graft can we use other than skin?
Yes, ma'am. Buccal mucosa can also be used, ma'am.
Any other easy thing? If a cesarean is going side by and it is elective and you have checked everything for viral markers, can you use anything from that?
Placental membrane, ma'am.
Amnion. They haven't seen
Amnion. Yeah. But you have to take care that the section is elective, free from all kind of infection, so that you can take out. It is basically takes up automatically.
Yes.
Okay.
Okay.
Any other thing you want to rule out in, we would say, MRK syndrome?
MRK syndrome can be associated with renal anomalies and skeletal defects, ma'am.
Usually uterine anomalies you will be associated with skeletal and renal anomalies.
Renal anomalies. Yes.
I can see Dr. Arun Kumar Majhi here. Sir, are you there?
Do you have any scope of prenatal diagnosis of this patient? Yes. In this case, prenatal diagnosis, can you do anything?
Sir, I'm not understanding, sir.
Can you just do something for prenatal diagnosis of this condition?
Prenatal diagnosis.
Yeah, prenatal diagnosis. It's difficult, no? It's okay.
Any other faculty having any other question? I think they have almost managed the case. After 5 minutes, it will be closed. Nothing remains of this case, so you can't ask questions then. So any other faculty have any other question, you can ask them. Dr. Durga Shankar Dash, Dr. Arup Kumar Majhi, are you there, sir?
Which all departments, like it will be a multidisciplinary approach in your case, or it will be like only gynae department has managed?
Ma'am, it will be multidisciplinary.
Which all departments you expect to be involved in this case management?
First is psychology, psychiatric
department for
department,
psychological education, ma'am.
endocrine department,
Endocrinologist, then gynecologist, and then
Plastic surgeon.
Plastic surgery.
You give them the option, they will involve all the departments, isn't it?
Yes. But these four actually should be involved.
Right. But it is extremely important, the counseling part and the, sex of rearing, the reproductive function, sexual function, all this counseling needs to be done. I wish we could have some, real life counseling in these sessions. We'll try in the future if we can do that, because these are extremely sensitive issues and the PGs must learn these techniques. How to, take them into confidence and talk to them, feeling as if she's or they are one of them, and not just giving them sermons, or not just giving them knowledge about this karyotype and the uterine transplantation, etc., etc. It's not an easy decision, very difficult decision. So with that, I think we will close this session here.
Hello,
Yes.
Ashish. Can I put one line?
Yes.
You just asked me to ask the questions, but I say both the girls have done so well. You have done enough number of questions. I was patiently listening, now also listening. Just I'm pretty happy that both the girls have done well. So please convey my message to them. They must be listening, because after putting them with so much of questions and inviting me and Naruvji further question, I don't think we don't anything more to ask. They have done nice.
Thank you,
Fantastic.
Dr. Durga.
God bless them.
That was Dr. Durga
Thank you,
Shankar Das, who prefers to be not visible, but sends his messages to the students. So students, you have done very well. Dr. Arup Kumar Maji is still not available. I think he has gone somewhere.
Both of them are presenting very nicely. So we congratulate them. Thank you.
They have answered almost all questions, sir.
Dr. Amrita. Amrita's special credit goes to her because she has, managed to
Thank you so much.
Different.
Thank you so much,
So
sir.
different yesterday. Now they have come out very well.
Congratulations to both the PVs.
So I will close this session here and now go to the next session. And thank you, the faculties, Dr. Karthika Prabhu, Professor, SRM Medical College, Chennai, Dr. Pranay Phukan, Professor and Head, Assam Medical College, Dibrugarh, Dr. Naina Kumar, Additional Professor, AIMS, Divinagar, Telangana, and Dr. Anuradha Panda, Senior Consultant, Apollo Day Health City, Jubilee Hills, Hyderabad. So all of you have contributed significantly, and I hope that the students have got some, direction towards presenting such kind of case of primary amenorrhea. Of course, if you go by the prevalence, the MRKH is much more prevalent, and MRKH is a common thing for the students and teachers. That's why repeatedly the MRKH was coming up in the question. But yes,
Sir, Ashish.
Yes,
Ashish sir. Sir, we had time actually, because I think we are before 15 minutes. I am not sure, Dr. Panikar, we had given his time to 1:30 because we expected the case go for at least an hour.
Okay.
An hour. So you can go and carry on. I'll just contact Dr. Panikar.
All the faculty's opinion. If they have any other question, Dr.
Or any. Sir, any questions is there in the chat box they can put on, and I can think you can go ahead a little bit more on the topic because we need to have some more time also. I'll just have Dr. Panikar.
There is only one opinion in the chat box, that is Dr. Shivani Bodapati has said high risk of gonadoblastoma in Swyer syndrome. That we have already discussed. Anything else that we need to discuss? Dear faculty members, you tell us. My appeal to all the teachers now, those of you.
Sir.
Yes.
Sir, they can get anywhere on in the amenorrhea topic, because it's a vast area, including the secondary amenorrhea as well. Because today in the quiz, they are facing all the questions for amenorrhea.
So any question of amenorrhea you can ask. Students can ask. Also, we can do them. We can, actually, amenorrhea is a vast topic.
Same case could have been presented with both testes and ovaries, undescended testes with ovaries.
Achha, my appeal to all the teachers, Dr. Naina, Dr. Anuradha, Dr. Amrita, and please, if you have FICOG, then it's okay. But if you do not have FICOG, kindly apply for FICOG online. Up to 31st October, if you get this, we will felicitate you at the Delhi ICOG.
We already have, yes.
Just see in your department who else is not having.
Sure, sir.
We encourage him or her to get the FICOG so that we can felicitate them in the Delhi eyes.
Sure, sir. We will do.
Yeah. And now coming back to amenorrhea, any other suggestion? Any the students want to know anything from the faculty members?
We can ask them about secondary amenorrhea if they want.
Yeah. No, in primary amenorrhea also you can ask many things.
Yes, yes.
A lot of things are there.
What are the hormone analysis they can, I mean,
One question coming up to my mind is what is her height like? I mean, height kitna bola iska?
161 something, you know,
161
161.
centimeters.
That means how much feet or inches mein batao?
Feet and inches. Around 5 feet 3 to 4 inches, sir.
5 to 3.
Actually, they are tall or short AIS?
No, in case
average
you
height.
plan to grow
Some-
her up in the male pattern, it will be a slightly short height. So, is there any way that we can increase the height?
We can give growth hormone before the epiphyseal closure, sir.
Okay. Now, I think Dr. Anuradha was coming up with some questions.
Any genetic tests you should be doing for these cases of DSD? Even in AIS, do you have any mutation studies?
SRY gene mutation.
SRY won't be here. That will be Sayers syndrome.
Favors.
Androgen receptor gene mutation is there, ma'am. So we can.
Yeah, what is
For
the gene even? Any CYP? We have to find out that even I forgot. But there is a gene mutation. Does
It
it?
will be 21A2 gene, ma'am.
Yes, I think 21 hydroxyl. Yes. You have mutation studies actually. If in case you have any doubts, you can, I mean, in the diagnosis, you can always do that. I think the CYP 21A2, I think.
Yes,
Yeah,
21A2.
A2, yes.
If the same case would have presented with a rudimentary uterus and ovaries, not that developed, but with the testes also, undescended testes. That is, they had both the gonads. Then how would you have approached?
Then we'll do counseling that whether they wanted to be reared as male or female, ma'am. According to the choice, we'll proceed the case, ma'am.
Okay, if she like ask you for female genotype, then phenotype.
Yes, yes, ma'am. Then we'll proceed with the bilateral test, gonadectomy. And then if
After
vagina
18 years, and then you'll put her on hormones so that her
hormonal replacement therapy, so that the secondary sexual characters will be.
So the first question in primary amenorrhea often comes as, what are the 5 important prerequisites for having a normal menstruation or menarche? Normal menstruation, normal growing girl. What are the 5 important prerequisites?
there should be a patent HPO axis, sir.
For that, genetics, you sir, always start with genetics. That means a normal chromosomes, female chromosome.
Oh,
Is it?
chromosome, sir, 46,
46.
XX, yes, sir.
Number
Yes,
one.
sir.
Number two.
Number two, there should be
Normal
normal.
hypothalamo-pituitary axis.
Hmm.
Then
Hypothalamus.
presence of
Then
there should be good
normal
ovarian
ovarian function.
ovarian
and
function.
normal.
And then there should be normal outflow tract, uterus, cervix, and patent vagina.
Genital organs. Okay.
Genital organs.
Hmm. And last.
That target organ response should be there.
Your target, okay.
Target organ, the role of two important accessory organs like thyroid and prolactin, that should be there, isn't it?
Yes.
So these are the 5 important prerequisites for having a normal menstruation. What is the normal age of menarche in our country?
So it is 15.
It's not 15.
15.
It is too late.
13 years of age. 13 years of age.
So you should always say a range in exam. Whenever they ask this question, you always say a range. 11 to 13 years, something like that. When is it called precocious puberty? When it is called delayed puberty? What is the normal sequence of developmental milestones in a girl?
There will be first thelarchy.
First is thelarchy.
Yes, sir.
Okay. Thelarchy after that?
After that, there will be adrenarchy, sir.
Then?
The pubarchy. Then there will be growth spurt. Then there will be menarche.
Thelarchy, puberty, then PHV, peak height velocity or growth spurt.
Yes, growth spurt. And then pubarchy.
Menarche.
Menarche. Menarche is the terminal event, right?
Yes, sir.
Okay.
How you define primary amenorrhea? Then you will be able to answer what sir asked precocious puberty.
Primary amenorrhea is defined as absence to attain menstruation by the age of 13 years in the absence of secondary sexual character, and by the age of 15 years in the absence of in the presence of secondary sexual characters, or
3 years.
3 years post thelarchy.
That means when you have the breast development or the suggestive features of breast development, then we give some time, considering that it may be a developmental delay. Constitutional delay or developmental delay, isn't it? Okay. So that is primary amenorrhea. What is secondary amenorrhea?
Secondary amenorrhea is the absence of menstruation for a period of 3 months in a previously normally menstruating female, or absence of menses for 6 months in a patient having irregular cycles.
Most common cause?
Most common cause is
pregnancy. You have to go to pregnancy and then PCOS.
Okay. Now, what are the common causes of this type of androgenic presentation? Like when there's a hirsutism and acne and all these things, hoarseness of voice. What is the common cause? Gynecological cause. Where from the androgen come from? One, you have said PCOS. Okay. Other?
Any other thing? Which is
androgen secreting tumors from the adrenal gland, sir. This is an hypothyroidism.
The ovarian tumor can cause this?
Tumor can cause.
Yes, sir. Yes, ma'am. Gonadal dysgenesis.
Not dysgenesis. Which ovarian tumor can cause?
Can cause hyperandrogenism.
Huh? Yeah. Even they can cause virilism also. So ovarian tumors which can cause hyperandrogenism, virilism.
Granulars. Sartori.
Adenoblastoma, islet cell tumor, isn't it? These are all.
Hicomas, they can also rarely secrete.
What are the sex cord stromal tumors? What are the varieties of sex cord stromal tumors?
So we have a yolk sac. Granulosa cell tumor, sir. Then we have Sertoli Leydig cell tumors.
What does a granulosa cell tumor commonly present with? Do they present with amenorrhea?
Hirsutism, sir.
They?
Granulosa cell tumor can present with menstrual irregularities, sir. Excess of there will be there will be menorrhagia in the patient.
Okay.
Can you enumerate the Mullerian anomalies in which a patient can present with primary amenorrhea? Different Mullerian anomalies where she can present with primary amenorrhea.
Mullerian anomalies like aplastic uterus, ma'am. Aplastic uterus. And
that is MRKHS. It can be cervical agenesis, can be vaginal agenesis. Okay, other than Mullerian, it can be septums, complete transverse vaginal septum.
Okay, hello, Dr. Hafizur, are you there?
Yes, sir, I am there. Doctor, I have contacted him. He's joining. He was telling, sir, in just a few minutes he's joining. He was in a surgery. That's what he said. Just in a few minutes, sir. I apologize.
Okay, so Hafizur, do you have any questions? We have done a lot of questioning here with the students on amenorrhea also.
Sir, any questions in the chat box? So is the Saloni, is there anything?
Chat box we saw, there is no question there. Okay.
So for the benefit of the students, because many of the students actually don't know that we are having all the programs are recordings are in the ICOG website. So they can go to the sites and just have access that, because we have many of the programs are repeated as well, so that they can have got from the knowledge from different faculties, maybe from the same on the same topic. That will be helpful for them to understand. So Dr. Panikar, sir, are you there? Dr. Panikar, sir, have you joined?
He hasn't joined. There is some question in the chat box. Satyika Reddy is asking why breast development was not there, sir. Breast development was there, no, in this case?
Was there?
Yes, Stana stage 2.
Stana stage 2 was there.
And 2 was.
Okay. Now this breast development is basically from the peripheral conversion of the androgen. Right?
Estrogen, yes.
So if you want further breast development, you have to have estrogen therapy, because this lady is XY. Okay. And there is another question. Can it be more clear, sir? What if patient wants to be a male? How to proceed? We have just discussed that. We need to help him. Sir, could you please elaborate on prenatal diagnosis? Prenatal diagnosis, I think we'll hold one session on prenatal diagnosis, because that's a very difficult thing and many questions are coming up. So we will take up prenatal diagnosis one day. It's a big thing, so we cannot discuss like that.
I just want to say something like,
Yes,
we
Amrita.
want to say thank you so much, Dr. Hafizur, Dr. Ashish Kumar, Dr. Anuradha Madam, and all FOGSI and ICOG office bearer for giving the opportunity to present a case, and for our PG students of AIMS Nagpur. So it was very informative, and it was like a very good preparation for the exam going students.
Yes. When are they facing exam? The third year students?
Around December, sir.
This
This
December.
December, sir. Yes, sir.
It's a good practice for all of you.
Yes, it was very good practice.
I'd like to thank you, sir, for giving the opportunity to present the case in this platform, sir.
We are having also PACE program, Postgraduate Academic and Clinical Excellence, that is running all over the country now. Just yesterday or day before yesterday, we had it at Lucknow. And now we are going to have it in Kolkata, 25-26. Okay, we had in Pune, we had in Hubli, different places we had this program. And it has got a huge response from the PGs. So watch out.
Okay, Ashish.
Yes, Durga.
Hello.
Yes, Durga, tell us.
Hello, Ashish.
Yes, Durga, I can hear you. Bolo.
So we come to an end. We had a nice discussion. We wish these two girls to get a case of primary amenorrhea in their exams in December. Okay.
Ashish, sir?
Let the girls be happy that they're destined to get the case of primary amenorrhea in December in their months.
Correct.
Ashish, sir?
Dr. Panikar is here.
Yes, sir. He has joined. I just technical team will ask to rename Dr. Panikar. He has joined the system, I think 943642. Can you rename from Saloni?
Yes, sir.
Please rename Dr. Panikar, sir. 943642 is his, I think, his system, so it will be better. Welcome, Dr. Panikar, sir. We can start the session, our third session, and Dr. Panikar is going. Dr. Vasudhava Panikar, sir, is an obstetrician gynecologist at EGM Hospital, Thrissur, Kerala. He is going to have his innovations way of dealing in one of the way to deal for PPH. So we'll have he will have demonstration on that session. Panikar, sir, are you there?
Dr. Panikar, sir, you are on mute, sir. Can you please unmute your mic?
Sir, Dr. Panikar, please unmute yourself. Yeah, he's unmute.
Yes.
Yeah, you're visible.
Okay, can you hear me?
Yeah, yes, sir.
Yes, sir. Now you are perfectly audible and visible, sir.
You want to share screen, sir?
Yeah, yes.
Yeah, please do.
One screen is being shared. One screen is being shared. Can you stop that?
Yes, ma'am. Let me stop your screen sharing.
No, one second.
Ma'am, it's done.
Yes.
Okay.
One second. Okay.
Ma'am, can I guide you how to share your screen?
We have started
sharing. Yeah, you can guide.
Ma'am, there will be a share option in green color.
Share.
Yes, ma'am. Share your entire screen.
Can you see it now?
Yes, ma'am. It is visible. Put it in ma'am, a slideshow mode, ma'am.
Yeah.
Slideshow.
എനിക്കായില്ല മേളിലേക്ക് മേളിൽ കൊണ്ടുവരാം.
സെലക്ട് എനിക്ക് ശരിയാണ്. അത് നാവിഗേറ്റ് ചെയ്താൽ സ്റ്റോപ്പ് ചെയ്യില്ലേ?
സ്ലൈഡ് ഷോയിലേക്ക് പോകാനായിട്ട്
Okay. I hope it's okay now.
Can you see
Yes,
me?
sir. Please go ahead.
Yeah.
Yes, sir. Please go ahead.
Yeah, I will start.
Yes, sir. Please.
Good afternoon. Thank you very much for this opportunity. I was little delayed because I had an emergency. Yes, now I had to do it. So a little delay has occurred. PPH cannula is the latest innovation in preventing and stopping PPH with almost 100% success. I had been using it, I have innovated it 12 years back, and I have been using it continuously for that. Now, many doctors, gynecologists in India are using it. I have presented it in many national and international forums. We'll start the session. This is my place. This is a slide made for another conference. These are the instruments that I have innovated. Nearly 25 instruments are there. 15 of them are patented. This is the PPH cannula. I will come to it later. This is a single-use PPH cannula. This is how it works. The PPH cannula is introduced into the postpartum uterus whenever there is huge bleeding or whenever you suspect huge bleeding. This can be inserted into the uterine cavity. Then it is connected to a suction machine and a negative pressure of 700 millimeters of mercury is produced. The uterine cavity will become closely opposed to the surface of the cannula, and the blood will be sucked out of the uterine cavity. And the pressure of suction exerted by the uterine wall onto the cannula will stop or close all the bleeders, and bleeding will be stopped. We allow 20 to 30 minutes. The same pressure is maintained, and by this time, clotting occurs in all these small vessels, and bleeding will be stopped permanently because the uterus is held onto the cannula strongly. The uterus cannot go atonic again. Moreover, there is one more principle. Whenever there is a huge pressure inside the uterine cavity, the pressure outside is normal atmospheric pressure. So the pressure tends to equalize. The intense negative pressure inside facilitates the uterus to contract towards the cannula and to equalize the pressure, and the uterus will remain contracted as long as the negative pressure is applied. So all these mechanisms play together, and 99.9% PPH will be stopped. Along with this, we can use uterotonics also, because different mechanisms will work in stopping the PPH. This will give near 100% results. These are all other instruments that I use for PPH surgeries. This is a mechanical Ventus suction machine which I use for PPH. Lot of advantages for this. This is the PPH cannula video. Please see it. It is with
This
audio.
is the PPH cannula innovated by me. This is 30 centimeters in length and 12 millimeters in diameter with multiple holes. This can prevent and stop PPH with almost 100% success. This is made of stainless steel. This can be used forever, and it will save
Sir, slides are not moving.
Bleeding from the postpartum uterus due to any cause. And this is useful even in DIC and patients with PA.
The slides are not moving.
This is quite inexpensive. See how I am using it. This is a case of severe PPH. I am using Panik's PPH suction cannula to prevent and stop PPH. Introduce the PPH suction cannula into the uterine cavity. by palpating the anterior lip of the cervix and then the internal os, make sure that the canal has reached up to the fundus. Then connect it to a suction machine to make a negative pressure of 700 millimeters of mercury. The blood collected in the uterine cavity is sucked out first, and the wall of the uterine cavity will be strongly sucked onto the cannula, and the pressure of suction will stop all the bleeding, and 30 minutes is allowed so that all the bleeding will be stopped by the pressure of suction and clot formation. This case was severe bleeding, so I put the cannula before suturing the episiotomy, and this very comfortable and convenient to suture the episiotomy if you put the cannula before suturing them, because there will not be any bleeding from inside the uterine cavity, and you can very comfortably suture the episiotomy. This is a breakthrough invention to prevent and treat PPH with almost 100% success.
Yes,
Total blood loss in this is nearly 200.
So can you see the thing? The slide is not moving, I think. Dr. Panikar.
Yes, Panikar, sir.
Yes,
Sir, your slide is not moving, sir.
Sharing is stopped. It is coming like that.
Oh, it is stopped. Okay.
It is paused.
It is paused.
Okay. Sir, can you please share your screen again, sir? Sir, I'm stop your screen sharing, sir. You can share it again, sir.
Okay.
Yes, sir. Sir, I have stopped your screen sharing. Now try to share it again.
Krishna. It's not coming.
Hello. Sir,
Hello?
can you please share me the presentation slides so I can share it behalf of you, sir?
I cannot do it from here.
Sir, you can share me the presentation slide in Zoom chat box, sir. I think there is network issue at your side. That's why it's happening, sir.
It is all stuck here. It's not moving.
Yes, sir. Because of the network issue, sir. Hello, Hafizur, sir. Hello.
Hello?
Sir, can you share the slide in Zoom chat box or anything
Is-
anywhere else? So I
The
can.
screen is stuck and it is not moving. I cannot close also.
Okay, so okay, sir, try to rejoin close that screen and try to rejoin the session, sir.
Yes, I will do it, but I'm not able to close it also.
Okay. So we can wait for 2 minutes to load if your PC is taking load, sir.
Krishna, അത് stuck ആയിപ്പോയി. ഇനി നോക്കാം. സ്ക്രീൻ സ്റ്റക്ക് ആയിരിക്കുക. ഇത് ക്ലോസ് ചെയ്തിട്ട് റീജോയിൻ ചെയ്യാമെന്നൊക്കെ ചോദിച്ചാൽ അത് എങ്ങനെയാ പറ്റുക?
സ്റ്റോപ്പ് വീഡിയോ അമർത്തി അല്ലെ സ്റ്റോപ്പ് ഷെയർ അമർത്തി
അതൊക്കെ അമർത്തി നോക്കിയതാ.
Hello, ma'am.
It is not, the screen is stuck and it is not moving in either direction.
Sir, can you try to shut down your device and restart it?
Hello?
Can you hear us?
Yes, ma'am. Yes, ma'am.
So the laptop is not working. The net has some issue.
Okay, ma'am, no issue, ma'am. You can share the slide to me. I will share it from my side, ma'am.
How to share it? It's a
Ma'am,
huge
you can
file.
share me on my WhatsApp or you can share me on my WhatsApp, otherwise in Zoom chat box, or I can share my mail ID, ma'am.
ഇത് ഷെയർ ചെയ്ത് കഴിഞ്ഞാൽ നല്ലോണം ഇല്ലേ?
Which will be convenient for you. Otherwise, you can share me your number. I will share a hello message on your WhatsApp, ma'am.
ഷെയർ ചെയ്യാൻ പറ്റില്ല.
അത് വലിയ ഫയലല്ലേ?
നോക്കാം നോക്കാം.
Okay, please send a hello to the number പറയൂ.
Ma'am, can you please share me your number?
94473
Just give me 1 minute. 98
944
944.
73.
Sir, 944. Your voice is breaking, sir. Can you please repeat?
9 4
9
4
4 4
4 4
944 10
73
73
51
51
590.
590.
ഇതിന്റെ അകത്തുണ്ടോ അത്?
ഇതിലോ?
ഇതില് ഫോൺ അതൊക്കെ അയച്ചു കൊടുക്കാം.
ഇതോ?
Yes, I will share hello message on your WhatsApp, sir.
Yeah.
അല്ല എന്നാലേ കാര്യം.
Share the videos. രണ്ട് വീഡിയോ ഇതിന് അയച്ചു കൊടുക്കാം.
ഫോണിലില്ലേ?
വീഡിയോ ഉണ്ട്. പ്രസന്റേഷൻ ആയിട്ടില്ലെന്നേ ഉള്ളൂ. അല്ല
ഇത് അയക്കണം.
അവരിങ്ങനത്തെ അയച്ചിട്ടല്ലേ അങ്ങോട്ട്?
അയച്ചു. 1 second, we are muting for the time being. Can you mute us now?
Yes, ma'am, let me mute.
Okay.
ഇതില്
അവരയച്ചിട്ടുണ്ട് ഹലോ.
Hi.
Ma'am, are you ready?
Yeah, Dr. Deepti. Deepti, are you ready?
Yes, ma'am.
Yeah, so we can...
Panikar, sir. Just 1 minute, Dr. Deepti, huh?
Sure.
Hello, Panikar sir?
Yeah, Panikar sir had joined, I think. I saw him.
Yes, ma'am. He joined the session, but if he has network issue at her side, that's why I'm sharing the screen on behalf of sir, ma'am.
Okay. So after Panikar sir, we are supposed to do the quiz, no?
Panikar, sir, are you there?
Panikar sir, can you please
Now
start
I
your mic and
saw
webcam, sir?
him logged in.
His
Saloni.
device can be seen as iPhone, I think.
iPhone
No,
Dr.
what is
Vasudeva
this?
Panikar. It's
Is
visible.
it presentation? Is it presentation or is it a video?
Ma'am, sir, it's there are 2 photo and 3 videos, sir. Panikar sir has shared with me, sir.
No, the photos is okay. If one of the video is there, short duration, you can share. Play the video. No, we'll have a few minutes.
Okay, so there is
Because
3 video. One, sir, I have 3 video. One of 1 minute, 2 minute, and 3 minutes, sir.
So please play the videos only. No.
Okay, so I will skip the photo then.
Yeah, skip the photos and play the videos.
Okay, sir.
Archana madam, just a few minutes.
So after the video, we are supposed to start the quiz.
Yes, ma'am. But she's telling it short video, 1 minute, 2 minutes, like that. So we'll have in a few.
After that,
Please share the video, Saloni, huh?
Okay, so let me share. Sir, this is first video.
Okay. This is the PPS cannula innovated by me. This is 30 centimeters in length and 12 millimeters in diameter with multiple holes. This can prevent and stop PPS with almost 100% success. This is made of stainless steel. This can be used forever and it will save all our mothers from the postpartum uterus. I'm using it. This is a case of severe PPH. I am using Paniker's PPH suction cannula to prevent and stop PPH. Introduce the PPH suction cannula into the uterine cavity by palpating the anterior lip of the cervix and in the internal os. Make sure that the cannula has reached up to the fundus. Then connect it to a suction machine to make a negative pressure of 700 millimeters of mercury. The blood collected in the uterine cavity is sucked out first, and the wall of the uterine cavity will be strongly sucked onto the cannula, and the pressure of suction will stop all the bleeding, and 30 minutes is allowed so that all the bleeding will be stopped by the pressure of suction and clot formation. This case was severe bleeding, so I put the cannula before suturing the episiotomy.
Okay.
And this very comfortable and convenient to suture the episiotomy if you put the cannula before suturing them, because there will not be any bleeding from inside the uterine cavity, and you can very comfortably suture the episiotomy. This is a breakthrough invention to prevent and treat PPH with almost 100% success. Total blood loss in this is nearly 200 ml. Thank you. Friends, I am here demonstrating how to use PPH suction cannula during cesarean section. Keep a PPH suction cannula connected with a silicone tube like this, autoclaved and ready. Please see the video. Extrude the uterus like this.
Don't suck or wipe the uterine cavity. Hold the lower edge of the incision, uterine incision, with the 2 Alice forceps, and then insert a dilator through the os to check the patency. Then introduce the silicone tube which is already connected with the PPH cannula like this. This will go into the vagina, and an assistant can pull the tube down through the vagina and connect it to the suction machine. It has gone down, and then like this introduced into the uterine cavity, and make sure that the cannula has reached up to the fundus. Now hold the edges of the uterine incision with Alice forceps together, like lower and upper incision together like this, and immediately you can start suction, and you can see the uterus contracting. Connected suction started. Suction started. See, the uterus is contracting. It has become pale also. It is stony hard now. See this one? So in whatever the cause of PPH be, even in placenta previa, you can, after removing the placenta, you can do like this, and the patient will be saved. See, it is stony hard. See the rugosity, and start suturing like this, and close the uterine incision. ഞാൻ തയ്ക്കുക കേട്ടോ സ്പീഡിന് വേണ്ടിയിട്ട്. This is the uterine incision after suturing. Cannula is inside. Now we can put the uterus inside the abdominal cavity. Lift the joints and put inside the abdominal cavity.
Thank you so much, sir. Dr. Paniker, sir.
Yes.
It was nice seeing you. I am sure all these students and everyone will get benefit and will get your insights of your PPH cannula, and hopefully it will be useful for many. I am sure for that. Thank you so much, sir.
Okay, thank you so much.
Thank you so much, sir. So we'll move on to our last session, that is quiz, which is one of the exciting session, and the postgraduate student keeps on tuned to this. So the topic is on amenorrhea, So I'd like to invite Dr. Archana Kumari and Dr. Dipti Gupta to take over and conduct the quiz with the rules, regulations. You can just initially tell, and please, over to you, Dr. Archana Kumari, madam, and Dr. Dipti.
Yeah, good afternoon, everyone. As usual, this is second Sunday of the month and very exciting PGICOG clinic quiz. And I'm indebted to Dr. Parag Biniwala for giving the quiz committee this opportunity. So today I am with Dr. Dipti Gupta, who is West Zone Coordinator of Quiz Committee FOGSI. And the topic is also a very rare one, but it is very important for a rare condition, but important for PGs. And today's topic is amenorrhea. And I must acknowledge Dr. Deepti's hard work in creating the quiz. So over to you, Deepti. You can start the quiz.
Thank you so much, respected ma'am, for the opportunity. It was actually, this is one of the topics which we encounter not so often, and therefore we don't read it up very regularly. And so it was actually one of the very, very satisfying quizzes that I had the opportunity to prepare.
It's a kind of
And
revision
at the
for us also.
Yes, and at the outset, I would also like to express gratitude to our FOGSI President Sunita Tandwalkar, Madam, ICOG Chair, respected Parag Sir, Vice Chair Ashok Kumar Sir, Secretary General Suvarna Madam, and all the coordinators, esteemed Sheila Mane Madam, Ashok Kumar Sir, respected Ashish Mukhopadhyay Sir, and of course Hafizur Sir. We know that they have been pursuing this activity diligently for the past so many years. So I would just like to start my screen share. Is the screen? No, not yet. Not yet. Is the screen visible to everyone?
Yes, ma'am.
Okay, just a second. I'm so sorry. I think I have done something wrong. Just go back. So the rules of playing on Kahoot, all the students are already familiar. There are multiple ways by which you can join the game. So first is that you can simply open any browser in your phone and type www.kahoot.it, and we are loading the game pin. Enter the game pin and you would be taken to the quiz. Second method is you can scan this QR code visible on your screen and play the game, or I am copying the link and sharing it in the Zoom chat box. So you can simply click on the right. So the link has been shared in the chat box, and I'll request the technical support team to please share the link, just copy and paste it a couple of times so that all the students can have the benefit of joining.
Okay, ma'am.
And as we can see, already participants have started joining in. So once again, I will just repeat the various ways by which you can join the quiz. You can scan the QR code being displayed on the screen. Second method is you can just click on the link shared in the Zoom window chat box and you would be straight away taken to this game quiz area. Third method is in the browser, you can type www.kahoot.it 6143818. And let me just tell you once again that we are not going to lock the quiz, which means even if you miss the first couple of questions, it is absolutely okay. You can join from the second, third question onwards. And it was a beautiful case presentation and discussion by the postgraduates of AIMS Nagpur. My heartiest congratulations to their mentors and guides who prepared them well. And a lot of students who were listening in will hopefully find the quiz fairly simple and easy to attempt. So we have about 24 logins right now in the quiz, and we'll wait for some more time before we start. And like, all the examiners were discussing that actually we tend to approach especially primary amenorrhea fairly simple, like, just get a ultrasound done and that's it. But we forget that in-depth assessment, whether it is actually a female phenotype or there are features of virilization, whether there are streak gonads, what is the karyotype, because they're going to have long-term implications on the health of the patient apart from the gender identity and the reproductive function. So it is extremely important that we start paying more attention to amenorrhea per se, both primary and secondary. So, ma'am, should we wait for some more time or should we start?
I think how many participants have joined?
Ma'am, 24 participants are there right now in the quiz.
Normally it is up to 50. I don't know what has happened.
Okay.
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 Maybe
So
we will wait for 2 minutes more.
Okay, ma'am. Okay, ma'am. In the
If,
meantime, I will.
if new are joining, then we will wait. Otherwise, if it is starting to at 2:24 for 2 minutes, we'll start.
Okay, ma'am. Okay, ma'am. And for the last time, I will repeat the instructions once again. There are multiple ways by which you can join the quiz. The quiz link has been shared in the Zoom chat box. Simply click on the link and you would be straight away taken to the quiz. Second method is you can scan this QR code on display at the top of the screen. Third method is that you can open your browser and type www.kahoot.it and enter this game pin 6143818. And then again, you will be taken to the quiz. And if some of you already have the Kahoot app on your phones, because it's a very, very common quizzing platform being used, then you can simply enter the same game pin in that Kahoot app. And I'll request all the participants present in the meeting to join. It is going to be a good revision of the entire topic because we have framed the questions in such a way that quite a few areas would be covered.
I think we can start.
Okay, ma'am. Okay, ma'am.
25
So I'm
to start.
Yes, ma'am. Starting the quiz now, and like we mentioned earlier, the quiz will be open. So in case you may miss first 1 or 2 questions, it is okay. And please remember, Kahoot has a dynamic scoring, which means that the time in which you answer is also important. For every question, the minimum time allocated is 30 seconds. Some questions which were a little long have been allocated 45 seconds. So on the left hand of the screen, you will be able to see the timer ticking in reverse. So you will know how much time has lapsed and how much remains. And that is important to keep in mind while attempting. So starting the quiz now. We have 30 participants and I expect more to join in the meantime, and best wishes to all of you. So welcome all to this quiz session as part of the ICOG PG clinic today. And the topic for today's quiz was amenorrhea. So the first round where we want to start from the start. And first question in this round is, identify this famous American endocrinologist. Is he Dr. Gerald Swear, Dr. Henry Turner, Dr. Robert Kalman, or Dr. Karl Rokitansky? We know that all of them have contributed significantly as far as amenorrhea is concerned. So who amongst these is this famous American endocrinologist? Last 5 seconds. Okay, I think some people took a little time to answer, so you will have to take care of this from next question onwards. And the correct answer was Dr. Henry Turner, who is obviously noted for the Turner syndrome, which he described in 1938. So looking at the scoreboard, Dr. Seema is leading right now. Moving on to the second question of this round. He described what is known as amenorrhea traumatica. I think it's a very, very subtle hint given in the question. Dr. Joseph Lister, Dr. McIndoe, Dr. Joseph Asherman, or Dr. Henrik Fritsch. So he not only described, but he also published what is known as amenorrhea traumatica. Time is passing fast. I request all to submit their answers. And the correct answer was Dr. Joseph Asherman. He was an Israeli gynecologist. Somebody is probably logged in with two devices. And Asherman syndrome has been named after him. Looking at the scoreboards, so a lot of people have opened their accounts and Seema continues to lead. Next question coming up in this round. Reliable indicator of endogenous estrogen is, this is again a very easy question. Is it adrenarche? Is it thylarche? Is it menarche? Or is it all of the above? Which is a reliable indicator of presence of endogenous estrogen? Last 10 seconds. And the correct answer is thylarche. So actually endogenous estrogen is can be kind of assessed by the degree of breast development, and secondary arrest of breast development is also suggestive of disruption of HPO axis. Also, it is important to remember that ideally menarche should follow thylarche within 2 years roughly. And pubic hair growth is suggestive of androgen production. Moving on to the scoreboard. So there is some shift on the scoreboard. However, Seema sticks to her position. Next question coming up in this round. This is again a fairly simple one. Evaluation of primary amenorrhea is indicated by all except by the age of 13 years in the absence of thylarche, by the age of 15 years with normal secondary sexual characteristics, within 3 years of thylarche if it has occurred less than 10 years of age, within 5 years of thylarche if it has occurred less than 10 years of age. When is it not indicated? And what are the other definitions of primary amenorrhea? And actually the correct answer was within 3 years. So it is recommended that if a patient has not had thylarche, then obviously by the age of 13, we need to initiate evaluation. With good secondary sexual characteristics, we can initiate evaluation by the age of 15. And if a girl has had early thylarche less than 10 years, then it is recommended that we can wait till for 5 years of thylarche before we initiate evaluation. Looking at the scores, Seema continues to lead, followed by Shri, Manisha, Aparna, and Shivani. Next question in this round, the last one in this round. True or false? Simple one. Secondary amenorrhea is defined as cessation of menses for 3 months or 2 menstrual cycles. Is this statement true or is it false? So, because we deal with primary and secondary both amenorrhea, when do we label a patient as having secondary amenorrhea? And the correct answer is this statement is false. Actually, the definition is in an otherwise regularly menstruating patient, minimum cessation of menses of 6 months or 3 menstrual cycle length is when we label her as having secondary amenorrhea and initiate evaluation. So let's look at the scores before we move on to the next round. And there is some shift. Shivani moves up, followed by Aparna. Moving on to the second round, where we will discuss handling hormones. The first question in this round is, Which symptom is typically absent in women with hypothalamic dysfunction? We know that there can be multiple causes for hypogonadism, and the patient can manifest with vasomotor symptoms, genitourinary symptoms, amenorrhea, etc. But in hypothalamic dysfunction per se, which symptom is typically absent out of these? So last few seconds left. All of you, please submit your answers fast. And the correct answer was vasomotor symptoms. So interestingly, in hypothalamic dysfunction, vasomotor symptoms are typically absent. And genitourinary, obviously the patient will have amenorrhea, so the answer possibly cannot be all of the above. And genitourinary atrophy develops gradually. Also, it is not very common in young women. Moving on to the scores. No change, literally. So the next question in this round. Subclinical hypothyroidism is indicated by, there are multiple combinations. So when we have elevated T4 normal TSH, low T3 normal TSH, normal T3 elevated TSH, and elevated TSH with a normal FT4, when would you suspect subclinical hypothyroidism? And it has become very, very prudent to evaluate and look for subclinical thyroid abnormalities in all the patients that we encounter, symptomatic patients. And the correct answer was elevated TSH with a normal FT4 is what is called as subclinical hypothyroidism. So it is important to screen for these women because they may progress to overt hypothyroidism. And we must also look for thyroid antibodies in all these patients. Moving on to the scoreboard. Up 3 places, Shrinit is the highest climber and Shivani has moved closer to Seema. Next question in this round is, hyperprolactinemia may be caused by all drugs except SSRIs, benzodiazepines, metoclopramide, or tricyclic antidepressants. So we know that a lot of pharmaceutical agents can be implicated with hyperprolactinemia, but which group does not cause hyperprolactinemia? And the correct answer was SSRI. Oh my God, I am surprised that nobody got it right because baki sare agents are established, culprits. Hyperprolactinemia can be caused by many drugs by either lowering of dopamine levels or inhibition of dopamine action. And they include amphetamines, benzodiazepines, butyrophenones, metoclopramide, methyl dopa, opiates, phenothiazines, reserpine, tricyclic antidepressants. In fact, a few months back, I had a 36-year-old patient keen to conceive. She had some issues and she was on some antipsychotic drugs. And she also had borderline prolactin levels. And we simply stopped her medicines after obviously consulting her treating psychiatrist and just put her on folic acid. And thankfully, she conceived. So, that is why it is very, very important that whenever we have a patient with amenorrhea or infertility with hyperprolactinemia, we must also dig into detail with any kind of medication because over-the-counter prescription medication is also very, very common in our country. So, looking at the scoreboard, Seema continues to lead, followed by Shivani, Shri, Manisha, and Shweta. Next question in this round is, other causes of hyperprolactinemia are all except. Now we are not talking about medications. We are talking about chest wall surgery, liver derangement, renal insufficiency, or renal cell carcinoma. One of these is usually not a cause of hyperprolactinemia, while other 3 are. So which one is not usually associated with hyperprolactinemia? Last 5 seconds, hurry up. And the correct answer was liver derangement. Again, nobody got it correct. So chest wall surgery, because of it causes, it sends the similar signals. So that is how it causes hyperprolactinemia. Other causes include cervical spine lesions, herpes zoster, especially if it is affecting the dermatomes, including the breast area. And renal insufficiency leads to decreased clearance of prolactin. That is how it leads to hyperprolactinemia. And of course, renal cell carcinoma and bronchogenic lesions can be the ectopic source of prolactin in some patients. So that brings us to the end of this round. And looking at the scores, Seema continues to lead. Moving on to the next question. Sorry, one more question here. Long-term use of cabergoline may increase the risk of hepatic failure, renal failure, valvular heart disease, or there is no risk involved and nothing to worry with long-term use of cabergoline. All of us have had patients where sometimes for a fairly long duration we need to give cabergoline, and cabergoline is also used in higher doses in cases of Parkinson disease. So which condition is associated with long-term use? And the correct answer was valvular heart disease. So we know that, two main dopamine agonists that we use, bromocriptine and cabergoline. Bromocriptine has a relatively short life with mainly GI side effects. However, cabergoline is a dopamine receptor 2 agonist with a longer duration of action. Of course, it makes the use very, very easy. However, it is known to cause hypertrophic valvular heart disease. It is postulated that it causes mitogenic stimulation of normally quiescent valve cells. And that is why if a patient is on long-term use, then we have to be careful and evaluate accordingly. So up 3 places, SSJ is the highest climber, and Aparna has kind of nudged Shivani from her place. Moving on to the next question. False about hyperprolactinemia is galactoria is associated in 50 to 75% of women. Symptomatic women with mild elevation may have macroprolactins. Thyroid disorder can cause mild elevation, and dopamine agonist is the preferred treatment. So which one of these is false about hyperprolactinemia? And the correct answer is galactoria is not associated in so many patients. In fact, only about a third of women with hyperprolactinemia will have galactoria. This is very important practice point. You simply cannot rely on the presence or absence of galactoria as a marker of hyperprolactinemia. Probably it is thought that because breast milk needs estrogen also to manifest galactoria, and women with hyperprolactinemia typically have anovulation leading to low estrogen levels. And of course, we know that thyroid disorders can cause mild elevation. So it is prudent that first we correct the thyroid abnormality and then we think about treating the prolactin per se if it is still elevated. So again, Shivani has taken a big jump, moving followed by Aparna and Shivani. Seema continues to lead. That brings us to the third round, that is Mullerian matters. And for this round, I request our committee chairperson and our guide and mentor, Archana Kumari ma'am, to please do needful and conduct the round. So the first question, ma'am, for you.
Thank you, Dipti. So this round actually is named very smartly as Mullerian matters. So according to 2024 ASRM committee opinion, the prevalence of Mullerian anomalies as percentage of primary amenorrhea is 15 to 40%, 10 to 30%, 5 to 25%, or 1 to 20%. Of course, the choices have got, they are close together, but we have to know about the ASRM committee opinion. Come on, PGs, you can attempt. There's no negative marking. So the correct answer is 15 to 40%. And sorry, only 3 of you could answer. But anyway, the scoreboard, again, Seema is leading the scoreboard. Next. What is true for MRKH? Genotype XXS, phenotype female, Macintosh procedure may be offered. Two types A and B may opt for gestational surrogacy, or all of the above are true. I don't know why 25 people have logged in, but only 5 answers are coming. I don't know whether they're having some problem in logging in or something. So the correct answer is all of the above. And I think most of you have got it right. That's wonderful. And it was relatively easy. If you know MRKH, this is a very common cause of primary amenorrhea. Next. Scoreboard again, Seema is at the top. Aparna has taken a leap. Next. Which does not differentiate complete AIS, androgen insensitivity syndrome, and Mullerian agenesis. Karyotype, serum testosterone level, pubic hair or asymmetrical sexual development, short blind vagina. Which does not differentiate? Okay, the correct answer is short blind vagina. This is found in both the cases. So 6 of you got it right. Next, let's have a look at the scoreboard. Seema persistently leading the scoreboard, followed by Sivani. I don't know who is N at the third position. So complete AIS, the gonad should be removed immediately as soon as diagnosis is made. True or false? Come on, this is, you have to mark either true or false, but this is very important fact to know. The correct answer is false, and okay, 8 of you got it right. Actually, gonad should be removed only after the secondary sex characters are developed. So that is important to know. Next. I think it is the scoreboard. Seema persistent leading at the top. Sivani is again at the second position. And Shri at third. Next. So that brings us to the end of round 3, and round 4 is on about puzzles of primary amenorrhea. And over to you, Dipti, for this round.
Thank you so much, ma'am. So here we have a few questions on primary amenorrhea per se. And the first question in this round is, false about Fragile X syndrome is, length of pre-mutation is stable and does not change over generations. It is the most common inherited cause of mental retardation and autism, often presents with premature ovarian insufficiency, and it is caused because of abnormal expansion of unstable CGG repeat sequence in the X chromosome band. So which one is wrong about Fragile X syndrome? And this is why I put this question here, because to highlight the fact that the length of pre-mutation, so Fragile X syndrome essentially is definitely the most common inherited cause of mental retardation and autism, and it is caused because of this abnormal expansion of the unstable CGG repeat sequences in FMR1 gene, which is located on the long arm of X chromosome. Normally, it is expected that there would be less than 30 repeat sequences, but in these women, more than 50 to 200 repeat sequences can be seen, and they usually present with premature ovarian insufficiency. Now, normally what happens is when a woman with POI comes to our clinic, we don't evaluate all of them for their genetic structure. But here, the length of pre-mutation is actually unstable, and the inheritance is complex because when it is passed on from mother to progeny, the expansion tends to increase leading to increased risk of Fragile X syndrome in each successive generation. This is a phenomena known as anticipation. So it is very, very important to test the women who come to us with Fragile X syndrome, especially if they have any features suggestive of mental retardation, autism, ADHD, etc., to rule out and to prevent further generations from being affected. So looking at the scores, Seema continues to lead, followed by Shri and Sivani. Ayushi Sethi has hit an answer streak of 5. Next question in this round, again a true or false question. Autoimmune thyroiditis has the strongest association with premature ovarian failure or premature ovarian insufficiency. Is this statement true or false? Answers are coming in last 15 seconds. Submit your answers fast. There is no negative marking. And the correct answer was false. Actually, the strongest association of POF is with Addison disease or autoimmune adrenocortical insufficiency. And it has been observed, interestingly, that these women have lymphocytic infiltrates only around secondary or antral follicles, not around primordial follicles, suggesting that the steroid hormone producing cells contain some inciting agent. So a look at the scoreboard. Shivani shifts up, followed by Shri and Sivani, and Ayushi is in the top 5 now. The next question, false about the 45X or gonadal dysgenesis. 45X gonadal dysgenesis is commonly known as Turner syndrome, dysgenesis with neurosensory deafness, also known as Perrault syndrome, typically short stature, web neck, shield chest, cubitus valgus seen, and good maternal prognosis in those who conceive, which is a false statement about this syndrome. Last 5 seconds. Good to see that more than half the responses were correct. Actually, these women have a fairly dismal maternal prognosis because of the associated cardiovascular anomalies. The other points are true. Ayushi continues to move up with the highest answer streak of 7, and Seema sticks to her position, leading the scoreboard. Next question in this round, false about management. Now we're talking about management of Turner syndrome. So treatment with growth hormone at any growth curve, estrogen therapy to be started usually between 12 to 15 years, oocyte donation is the fertility treatment of choice, and the risk of death during pregnancy is almost 100-fold. Which statement is false about management of Turner syndrome? Last 5 seconds. Submit your responses. And the correct answer was, good to see that almost half of them got it right. Treatment with growth hormone is actually to be initiated when the growth curve falls less than 5th centile of the normal female growth pattern. And estrogen therapy always is started at the low dose option. And the goal is to complete maturation over 2 to 3 years at a slow and gradual pace. So moving on to the scoreboard. See, Shivani has again come up. Next question. Karyotype 46XX, normal internal genitalia, present with primary amenorrhea and delayed sexual maturation, and oocyte donation is recommended for conception. So which statement is false for patients with Sware syndrome? Half the time is up. Responses are coming in. Very happy to see this. Actually, it is a 46XY gonadal dysgenesis, where the female phenotype is seen because the dysgenetic gonads produce neither AMH nor androgens. So the default female development takes place, and a mutation of SRY gene on Y chromosome is implicated in almost 15-20%. They present after the expected time of puberty with delayed maturation and primary amenorrhea. Normal adrenarche, there is pubic hair, so it rules out complete AIS. And another important thing to note here is that gonadectomy is indicated immediately at the time of diagnosis, soon after diagnosis, because of the risk of malignant transformation is as high as 30%. They can be reassured about female gender identity, and of course, donor IVF is way to go. Up 4 places, Aditi K is highest climber, and Aparna has moved up to the top 5. Next question on your screens. True about type 1 autoimmune polyglandular syndrome is adult onset, commonly known as presence as hypoparathyroidism and mucocutaneous candidiasis. Mutation in AIRE gene is known to be associated. Premature ovarian failure seen in about 60%. A, C, D are correct. B, C, D are correct. So which is the correct option out of these? That is why we gave a little extra time in this question. Now last 10 seconds. And the correct answer was BCD combination. That is commonly presents as hypothyroid, parathyroidism, and mucocutaneous. Mutation in AIRE gene is known, and POF seen in about 60%. So a type 1 APS is also known as autoimmune polyglandular APS. I'm okay. Now moving on to the scoreboard. Seema P continues to have the highest answer streak of 4, followed by Aparna moving to the board. Next, this brings us to the last round of the quiz, some miscellaneous mania. Which is not a high gonadal toxicity agent? Cisplatin, busulfan, cyclophosphamide, or chlorambucil? We know that a lot of chemotherapeutic agents are used for various gynecological malignancies, and we should be aware of the toxicity potential so that we can offer some kind of fertility preservation to the patients. And the correct answer is cisplatin. The others, busulfan, cyclophosphamide, and chlorambucil, are high gonadal toxicity agents. So this is just something that we need to remember. 3 in row guys back in the game, and Seema is followed by Shivani, Sivani, Shri, and Aparna. Next question in this round, again a true or false question. GnRH agonist pre-treatment before chemotherapy does not reduce or delay premature ovarian insufficiency in these patients. So GnRH agonist pre-treatment is of no help before chemotherapy. Is this statement true or false? And actually the correct answer is this statement is false. GnRH agonist pre-treatment has been postulated to help. It has been observed that in women pre-treated with agonist had less than 10% chance of irreversible premature ovarian insufficiency compared to 40 to 70% who had no pre-treatment. And the postulated mechanisms are that because of the suppression, it decreases the number of primordial follicles entering the development phase, and also it decreases the perfusion to the ovary, therefore decreasing the reach of therapeutic agents to these follicles. So moving on to the next question, scoreboard. Now Gai has moved to top 5 with an answer streak of 4. Next question. Genotype XX, normal phenotype, normal AMH, normal AFC, high FSH LH, low estrogen amenorrhea is seen in. Please read this carefully. So can this be PCOS? Can this be galactosemia? Is this Kallmann syndrome, or is it Savage syndrome? XX, normal female phenotype, normal AMH AFC, but high FSH LH and amenorrhea. So happy to see that 3 people got it correct. Actually, it is Savage syndrome or the resistant ovary syndrome. So to our dear friends who marked PCOS, we don't see high FSH ever. LH may be high. In fact, it is mainly the LH-FSH ratio which might be reversed, but we never see high FSH in women with PCOS. And therefore, it is WHO type 2 disorder of ovulation. So looking at the scores, Seema followed by Shivani, Sivani, Shri and Ghai. Next question. Anorexia nervosa is marked by maybe restricting or purging variety, low FSH, LH and estradiol, considered a WHO type 1 dysfunction, and all of the above. So what are the various features which are characteristic of and or identify anorexia nervosa? And the correct answer was all of the above. This was one of those just learning questions. And it is very important that whenever we get a patient of hypogonadotropic hypogonadism, let us not jump to, HPO suppression because of some genetic cause itself. There can be so many other lifestyle or, eating disorders involved as well. So we must get into detailed history, and anorexia will have all these features. So Seema has the highest answer streak of 3 and continues to lead the scoreboard as till now. True about Kalman syndrome are all except can affect both males and females, X-linked inheritance affecting CAL gene, delayed growth and sexual development, pubic hair helps distinguish from constitutional delay. One of these is not true. So which one is not true about Kalman syndrome? And the correct answer is it is not X-linked inheritance affecting CAL gene. In fact, there are three different patterns of inheritance associated with Kalman syndrome, while the others are true. It can affect both males and females. These patients will present with delayed growth and delayed sexual development, and the presence or absence of pubic hair will help in distinguishing these patients from constitutional delay subset. So Sivani Bodapati is making a comeback with 3 correct in a row. Next question. Incorrect about Sheehan syndrome is posterior pituitary is affected, also known as postpartum pituitary necrosis. Failure of lactation is the earliest presentation, and Addisonian crisis and diabetes insipidus are known complications. So which one is not a feature associated with Sheehan syndrome? In my residency, I had seen one case of Sheehan syndrome. In fact, in all these years, I have seen, thanks to the prompt and excellent management of which is affected, and the others are correct. So Seema continues to lead, followed by Sivani and Shri. Next question, again a true or false question. COC may be used, that is combined oral contraceptive, may be used to improve bone health in functional hypothalamic amenorrhea. Is this statement true or false? So yes, we do have a condition called functional hypothalamic amenorrhea. And for these women, are COC enough to improve bone health? Last few seconds. And the correct answer is it is not enough. We actually need proper estrogen therapy COC has very, very low dose. It does not help to improve bone health in functional hypothalamic amenorrhea. And functional hypothalamic amenorrhea is a diagnosis of exclusion. So up 3 places, SSJ is the highest climber. Who knows, by the end, we may see him or her in the top 5. Which is not a component of female athlete triad. So there's something called as female athlete triad. And there are few features: low energy availability, high bone mineral density, menstrual disturbances, and low bone mineral density. Which one of these is not a component of this female athlete triad? Last few seconds. And the correct answer, happy to see that quite a few got it correct. These women actually suffer from low bone mineral density. And that brings us to the last question of today's quiz. Incorrect about Asherman syndrome is: infertility is the most common presentation, hysteroscopic adhesiolysis should be done, high risk of recurrence, classification published in 2000 by Nasser et al. Is a clinico-hysteroscopic classification, energy source to be avoided, adhesion prevention strategy recommended after adhesiolysis. So which statement is incorrect about this condition? With judicious use of uterine curettage, both in obstetric and gynecological conditions, it is a potentially avoidable condition. And the correct answer, which only one person got it right, actually menstrual abnormalities, oligomenorrhea, amenorrhea, is the most common presentation. Infertility is not the most common presentation of Asherman syndrome. All others are correct. That brings us to the end of today's quiz, and let us have a look at the podium. So at the 3rd position, we have Shri. At the 2nd position, we have Shivani. And leading the podium, no guesses, we have Seema P. So that brings us to the end of today's quiz. And once again, I'm extremely grateful to Archana Kumari ma'am and the entire ICOG PG Clinic team. I see Ashish sir smiling. Sir, would love to hear your feedback.
Congratulations, Seema, for winning hands down the PG quiz.
Yes.
Wonderfully conducted by Dipti and our Archana. So I think that it's a very good addition in the PG clinic. We'd like to see more and more participation in the next years to come, the next months to come. So thank you very much. And I believe that it is going to be more, is this, tell me, Dipti, are the number of questions increased this time?
Sir, usually we try to have 30 questions. I think it was somewhere around 30 only this time also.
Time it was 37 questions.
Okay. Sir, the slides were 37, but that included the round slides also.
Okay. So thank you very much, Dipti. And
thank you, sir.
On behalf of ICOG, I thank everyone involved in this. The ICOG chair, vice chair, president of FOGSI, secretary general, the quiz committee of FOGSI, all the faculty members. Thank you very much for participating. Thank you.
So, sir, thank you. So with that, we are closing this link. Thank you.